everyone. Thank you very much for coming today for this fantastic meeting that has a great lineup. Excited to see so many friends for many years. And just a few housekeeping informations. I would like to remind everyone to stay on time, to respect the time. I would request from moderators to give 1 minute's notice to the speaker. And without a further ado, I would like to invite the first session, which is session on innovation. Moderators are Dr. Liu and Dr. Butarbush from Taiwan and Morocco, respectively, to take the podium. And as they are logging in or opening their microphones, I would like again to thank Professor Salman Sharif and Mehmet Zileli for their hard work over the past year as a chairman of committees and chairman of education committee. They did fantastic job and carried on the legacy that we established 4 years ago, and I hope next term committees are going to flourish even further. So Drs. Liu and Dr. Butarbush, please take the podium.
Thank you, Professor. We start with our first session on innovation session. I'm Liu, and I will be moderating this session with Dr. Majoba. We have 4 eminent speakers here. We will start with our first speaker, Professor Mirza Pojoski, who is a consultant neurosurgeon at the Department of Neurosurgery, University of Hospital Marburg, Germany. Who is also a fellow of the European Board of Neurological Surgery, and today he will speak to us on robotic surgery. Let us welcome Professor Mirza. 8 minutes, Prof.
Thank you.
Sorry, can I just request Luis Baba is here, so I thought he was busy, but he's available. So Luis, can you say a few words? We'd appreciate that. He's our president-elect. Luis. Where did Luis go? Okay, you can carry on. Maybe I don't see him anymore. You can carry on and we can join, ask him to join later.
Prof. Mirza?
Please start, Mirza.
Yes, second.
Dr. Poiskic, can you start your presentation? We are all waiting.
Mirza, can you hear us? Mirza is frozen. Can we move on to the next talk and then?
He's saying he's joining. So he's joining in a minute.
Can we move on with the next speaker and Mirza can join later, please?
Yes, sir.
We
Yes,
move on to the next speaker. I call upon Dr. Majoba to introduce our next speaker, Professor Lim. It's okay. I think while waiting for Majoba, let us call upon our second speaker, a keynote speaker, Professor Lim Kang Teck, who is a Korean neurosurgeon, a famous sniper, from Korea who are recognized as pioneer in the field of minimal invasive surgery, particularly in his development of percutaneous stereoscopic lumbar decompression technique. And he also the president of good Dr. Ten Spine Hospital in Korea. And everybody know him. I think the whole world know him, and he has known for his advanced work in endoscopic spine surgery. And today he will give us a keynote talk on endoscopic spine surgery. Let's welcome him, Professor Lim, please.
Hello.
Yes, we can hear you, Prof.
Okay. Sure. Bye. Okay. Can you hear me?
Yes, you may
Okay.
proceed.
Okay. Hello, everyone. My name is Lim, Korean neurosurgeon like you. Good evening. It's 9 o'clock in Korea. Thank you for having me today. Today, I would like to briefly introduce what kind of spine surgery is possible with endoscope for young neurosurgeon today. So in Korea, sorry. Okay. Okay. So as a development about the preventive medicine in Korea, early 2000, total case of brain surgery and trauma case have been decreased. So neurosurgeon had to shift to spine surgery from the brain. So we had to focus on endoscope spine surgery. So endoscope spine surgery is the most commonly performed spine surgery in Korea and account for more than 70% of all spine surgery. So spine surgery is endoscope is led by neurosurgeon in Korea than the orthopedic spine surgery. And even the patient knows it's very familiar to searching internet what is the endoscope spine surgery. They are the patient want to get the endoscope spine surgery in Korea now. In 2016, so I made by myself a new endoscope system with the Maxima, the spine company is my disclose. And with the endoscope, we can do not only discectomy, we can do the foraminotomy or spinal canal decompression, but also the fusion surgery, lumbar, and HDF. So today I talk about this. And for young neurosurgeon, I think the endoscope spine surgery is not option, but must in the near future. That's why the young surgeon do not performing endoscope spine surgery. So the total case of the spine surgery will decrease. So let's look at the lumbar is the one level lumbar the stenosis and pre and post operative. So we can do the decompression. But you can see the CT scan shows no any damage of a facet joint, and the narrow space you can do bilateral decompression. So one level and the two levels, so two level like this, and using endoscope. But during the operation, its advantage could be the bleeding is very less, and the patient have stenosis and the left side disconation. So we have to decompress bilateral and then discectomy also. It's good indication for endoscope and 3 levels also. 1 pre and post operative, 1, 2, 3. Right? With one skin port, we can do 1 skin port, we can do 3 level. It's a jumping technique. A jumping technique means first using the same skin port, we can do 3 level, but have to the fasciotomy at each level, and then after that we have to insert the drain at each level to prevent hematoma. And the 4+ operation is a 4 level with 1 skin port, 4 level central decompression, and 2 level is foraminal stenosis. It's a 4+ operation. We can do with a 2 skin port, we can do 4 level and 4 level central and 2 level foraminal stenosis decompression. So about the fusion surgery, so our path the next speaker, Dr. Hyun-Sung Kim, will talk about this fusion surgery. Yes, and then I move to the cervical case. Cervical, we can do endoscope, we can do posterior decompression, spinal cord, and then anterior approach HDF endoscopy. So cervical myelopathy is one of the challenge for overcome as an endoscope spine surgeon. So usually the debate in the spine complex endless and the constant debate was anterior approach better, posterior approach better is what the debate. But we have another option is posterior endoscopic decompression and endoscopic HDF. Anyway, the open surgery, the problem could be the detachment muscle and will leading to eventually patient will have a atrophy muscle and the kyphotic change postoperatively. And endoscopic spine was introduced in 2016. Our team before the 2016, my team was the 1 year laminoplasty case was 20, and the Microsoft HDF was more than 80 cases. But the Microsoft HDF was replaced by endoscopic HDF, and the laminoplasty was no longer necessary because you can do endoscopic decompressions. So in case of myelopathy, need to check and dynamic MRI to know location of the pathology. This patient is the same. A patient that has posterior buckling ligament. Just that's we had to remove this only, the posterior buckling ligament only. The first choice of cervical could be posterior decompression. With one skin port, we can do multiple level decompression, full level decompression with one skin port, and then even the long level decompression, we can preserve posterior ligament complex. That's why the post-operative kyphot change is very less. And then also we can avoid the laminoplasty HDF can be avoided. So posterior approach we can do spinal canal decompression or foraminotomy. So we can do axial portion, sensory motor route, and then causal route to the sensory part. Yeah, like this. And then one of indication could be the paracentral disc and post-operative we can do endoscopy, post-operative discectomy, and the foraminotomy also. Pre- and post-operative, but we can preserve posterior ligament complex. That's why there is no any the instability post-operatively. Pre- and post-operative, and then one level decompression like this, and the 3 level, 1, 2, 3, and then 3 level with one skin port. It's a sliding technique. 5, 6, 6, 7, and 4, 5. That's why the laminoplasty was no longer necessary. It's 1, 2, 3 level for the spinal canal decompression. 3, 4, the 4, 5, it's 5 or 6. It's a sliding technique. Okay? For spinal canal decompression from ipsilateral to contralateral side, and with one skin port you can do. So for slide technique, you can find my chapter in the textbook, full level also, but there is no any the kyphot change post-operate because we can prevent the damage of the preservable of the posterior ligament complex. And open surgery, we had to preserve fascia joint more than 50% to prevent the instability. But the endoscope, there is no any the damage of posterior ligament complex, so there is no any the instability. That's why in case of the orthopedic case, the total sometimes it total remove the fascia joint is not lead to the instability post-operatively. its advantage could be, I think, endoscope post approach, we can preserve post ligament complex, very important to prevent the instability. It's about, let's move to anterior approach, the endoscope spine surgery. So a patient have the calcified disc, and we can do endoscopic anterior approach and discectomy, and you can insert the cage. Advantage endoscope HDF could be, the system will provide good visualization and will guarantee safety. And operation time, the word around 1 hour is enough, and the post-operative anterior soft tissue swelling is very less. So, the advantage of endoscope for this. So approach is the same like open surgery between esophagus and the keratosis. And we will push the anterior visceral organ to opposite side with the finger, and we can insert the needle and the serial dilator. And then we can use the endoscope system and the discectomy and then insert the cage like this. This is the perimeter fascia. And then after remove the perimeter fascia, we can expose disc space, and using endoscope system, we can do the discectomy and then remove PLL. And under the endoscope view, we can insert cage, and then finally, we have to insert the drain to prevent hematoma. From the 2017, my case is 250, and the outcomes and cervical lateral, the corpse angle, the disc height was good, and then also the all 100% of the fusion rate is my paper like this. You can do midline corpectomy, central corpectomy. You can do the endoscopic discectomy and insert the cage like this. It's a video. You can remove the calcified disc, and then you can see dural position. And then before the insert the cage, we have to insert first like this holder, cage holder, and then under the endoscopic view, you can insert the cage like this.
Mr. Lim,
Yeah. Yes.
yeah,
Okay.
there's time's up.
Okay. I'll pass. Okay. So anyway, you can do the C1 to high cervical under thoracic also. Time too short. You can do the endoscopic, the IDM tumor also like this. I'll pass thoracic, and in conclusion, endoscopic operation will guarantee passive return to the patient life, and we can change the indication of the method of surgery, and the total case of the fusion surgery has been decreased. And for young surgeon, it could be the new field for young surgeon who want to become the spine surgeon. So born was the first to destroy the world, Dr. Haram has said also. So I direct to the young surgeon, let's crack the air and go out into the new world. Thank you.
Thank you to Professor Lim for excellent talk with a lot of innovation in
Sorry,
different
it's
techniques.
too short, the time.
Yeah, so sorry. Let's call Dr. Manjuba to our next speaker. Doctor.
Yes, we are pleased to welcome next speaker, Professor Mirza Ucik from Department of Neurosurgery, Marburg, Germany, to talk to us about robotics in spine surgery. Thank you.
Okay, So, hello everyone. Can everybody see the screen?
Yes.
Thank you. So, thank you for the kind invitation to WFNS Young Neurosurgeons Conference. My name is Mirza Poyskic. I'm a consultant neurosurgeon from University Hospital Marburg in Germany. And I will talk today on artificial intelligence and robotics in spine surgery. So when we talk about artificial intelligence, we have its role in perioperative AI for imaging, planning, and prediction, in intraoperative navigation, robotics. I will go shortly through evidence on accuracy and outcomes, and shortly through what's next, safety, regulation, and autonomy. There is a whole new field of neurosurgery called computational neurosurgery. It uses computational modeling and artificial intelligence, where it's used to improve diagnosis, treatment, and prognosis of patients affected by neurosurgical diseases. And these are its different parts, from artificial intelligence, deep learning, fractal-based neurosurgery, graph theories, computer vision, Bayesian neural networks, AI in brain tumors, and virtually in every part of neurosurgery, application and integration of radiomics, radiation neuro-oncology, computing, and the brain connectome concept. And the first conference of this new field of neurosurgery is going to take place in Sydney in February. And for all freaks of AI and robotics, there is also a very good meeting in Paderborn in Germany in November this year. So where does the AI fit in the spine pathway? In pre-operatively, in automated imaging and segmentation, CT and MRI landmarking, screw trajectory planning. I'm going to show it on the example of our robotic arm. Patient-reported outcomes measures, based risk stratification, shared decision-making, intraoperative AI-assisted navigation, computer vision tracking. And safety filters for robotic trajectories, and machine learning models to predict pain, disability, and discharge following the surgery. Now, prediction and planning in outcome predictions, there are large registry machine learning models, over 22,000 patients, which show good discrimination and calibration for 12-month pain and disability after surgery of the lumbar herniated disc. It can be used for individualized prognosis and counseling. There are deep learning tools which can auto-plan lumbosacral pedicle screws with very high qualitative grades, and that's something which I use in my daily practice. Deep models can recognize implants, pedicle screw brand on plain films to support revision planning. They are safe deep reinforcement learning, which adds distance-based safety filters for online screw trajectory planning in robotic workflows. And the reviews are showing the rapid maturation from decision support to closed loop assistive autonomy. All the reviews and all the literature which is published so far shows that there is a very high pedicle screw accuracy with robotic platforms and with superiority to conventional techniques. And that's actually the ratio to use it. And this would be intraoperative CT in our institution, which we combine with augmented reality and automatic registration. However, since today's talk is on robotics, I will just go shortly through the definition. It's any reprogrammable powered manipulator with artificial sensing that can assist in a variety of surgical tasks. And the first robot was Puma 200 from the 1980s. This is the photo of it. And the robots of today are actually working in a very similar way. You can classify them as passive, semi-active, and active devices. And you can further classify them into supervisory controlled robotic systems, which are very rare, robotic telesurgical systems. Neurosurgical example would be implantation of DBS electrodes in a teledistance mode, and shared control system, which are actually robotic arms which we use. Robot and surgeon remain jointly in control. The surgeon remains in control of the procedure while the robot provides steady hand manipulation of the instrument. And actually, we talk about cobot surgery. So robot assists with the distinct but critical and difficult task of the operation. It's either step of anatomical localization, stabilization of the surgeon's hand, or targeting of the pedicle screws. This is photo of me in my OR with the Circ robotic arm. which is generated through ChatGPT as a cartoon character. I always place this photo in order to show how artificial intelligence and its rapid development, which is going from day to day, is actually changing our daily practice, and that the robotic guided spine surgery 2 years ago was less automated and less autonomous than it is today, only thanks to this development, and we can see practically the differences on a monthly basis. So AI-driven robotics in neurosurgery, it enhanced precision automation, AR-powered robotic system, integrate real-time data processing, and allow for more precise tumor resection, electrode placement. It can analyze past surgical data to optimize robotic trajectories, and AI models can process intraoperative imaging to adjust robotic instruments dynamically, improving safety, delicate brain and spine regions. And the key synergy is that AI processes electrophysiological data, imaging, and robotic feedback to refine augmented reality overlays as well as robotic movements. And the most notable breakthrough is since the generative AI has such a big development in the last 2 years. However, currently robotics is used only for assisted pedicle screw placement or placement of K-wires. However, there are first reports on automatic or semi-automatic robotic laminectomies. There are a lot of robotic systems which are in use, and Pro is high pedicle screw placement accuracy, 97 to 99%, which decreases revision rate, complication rate, and it's applicable with ORM and intraoperative CT. Of course, the big problem is the cost and the longer operating time, as well as technical issues. And there is a growing body of literature which shows the superiority of robotic guided pedicle screw placement in a comparison to other techniques. We have an age of active robots for pedicle screw placements. These are the 3 publications from our department since we have initiated the robotic guided spine surgery with BrainLab Circ robotic arm in year 2021. They're all open access papers, so everyone who has an interest can check it out. And this is our intraoperative setting with intraoperative CT and robotic arm, and these are the workflow steps. Preoperative imaging, according to which we plant the screws, then intraoperative imaging with automatic registration. We fuse intra and postoperative imaging. We robotic assisted implant the K-wires, and then fluoroscopy assisted insert the pedicle screws. These are the photos from the OR and the placement of the reference array, the fusion of the images, and then the implantation of the K-wire. You bring the active, the head of the robotic arm to the trajectory of the entry point. It aligns automatically to the pre-planned screw trajectory. You place the K-wire, and then after that, the pedicle screw. Now, we have AI models which can automatically plant the screws, the pedicles, and the trajectories. And all of that can be seen in our open access publications and operative videos on the links which I have shared. Thank you very much.
We have 1 minute for the question. Any question from the floor? Maybe one question from me, Professor. May I know that if you use robotic, what are the most important precautions since you are not alone? Thank you.
The most important precaution is to keep anatomy in mind and not to rely on anatomy, and not to over-rely on technology, because if the robot, there are many technical registration and installation issues which you need to be careful about, especially the unintentional movement of the reference array and registration inaccuracies. And the surgeon should always keep in mind the classical anatomical and surgical knowledge, and keep in mind that the robotic surgery is just an addition and just a help, but not something which will do the thinking for you.
Professor Mirza, for a nice, excellent talk. Let's move on to our third speaker. You give me a great honor to call upon Professor Hin Sun Kim, or known as Harrison Kim, who is the director of Harrison's Spinatus Hospital in Chundam, Korea. He's also the editor-in-chief of Journal of Minimal Invasive Spine Surgery and Technique, a section editor of World Neurosurgery, Neurospine, IJSS, and associate editor of BMC Musculoskeletal Disease, and academic editor of medicine, guest editor of brain sciences. And today he will give us a keynote lecture on endoscopic lumbar fusion surgery. Professor Kim.
Thank you so much, Dr. Bunseng Liu, and hi, good morning, Professor Salman, Sandeep, and Professor Mehmet and Majuba. It's a long time no see. Today, my topic is some endoscopic lumen fusion surgery. Dr. Kang Taek-nim already mentioned that the endoscopic spine surgery in Korea developed so much, and mostly degenerative disease treated by the endoscopically, spinal disease treated by the endoscopically, and mostly it related by the neurosurgeon, especially, and also nowadays young neurosurgeon, they started endoscopic spine surgery so much. This is my curriculum by then disclosure. Now, if we met like this patient, we hope maybe can treat it by the endoscopically not open, and reduction can sufficiently make some fusion sufficient that will be the best treatment for this patient. Actually, the endoscopic lumbar fusion nowadays can approach it by the three approach technique of transcambing approach, and the posterior approach, and post-lateral approach. Among them, I use this post-lateral approach mostly. And the first step of the endoscopic lumbar interval fusion of the post-lateral approach can resect the IAP is sufficiently because of that. The firstly point is that the finding the Kim's point is the starting point of the drilling, and then we can see that some very easily a resection of IAP, and that the same method we can resect the SAP by the from the lateral to medial from the upper above of the pedicle. Then you can see the resection of this area. After that, we can finding the foraminal space sufficiently, and then insert the working channel to docking to here. Then next step is very important to that. Sorry. Sorry, video not play. Sorry. Yes, then we can insert the working channel to the canvas area. Then the next step is very important is that some chronic adhesive disc drilling is very important to releasing the collapsed disc like this. And the next step also very important thing is that the end plate denudation is some increasing the fusion rate and decreasing the substance that make some very rapid fusion process can make it, and decreasing the substance more sufficiently. And after that, resect the chronic adhesive disc drilling, and then end plate denudation, we insert the cage with using the Harrison cage glide that protect the traversing and the acute nerve root together like this. Then finally insert the cage to the target point like this way, and then like this. And then you can see like this severe collapse spondylolisthesis cases using the endoscopy lumbar fusion, and then insert the cage like this way. And sometimes we can insert the two cage insertion is possible to increasing the substance fusion rate, and then finally fixate using the percutaneous screw. And then you can see the finally the single level fusion scansion is decreased so much, meaning that all structure can preserve the completely, meaning that some second junctional problem or some instability not easily not happen after endoscopy lumbar interval fusion. Scientifically, endoscopy lumbar interval fusion already published so much. In my paper, Kim's point already published in the brain sciences. Also, Harrison Glide also introduced this in the all the neurosurgery. Also, in this paper, using the chronic adhesive disc drilling and endoplate denudation have a very, very big advantage compared to the open surgery. For example, you can see like this severe collapse disc increasing the focal segmental correction is very effective, and also severe collapse disc also restored very sufficiently, and also spondylolisthesis can sufficiently reduce like this way. And also in my another paper talking that using the end plate denudation and the 3D printed cage, we can make a very rapid fusion process and very high fusion rate. For example, like this case is of some osteoporotic older patient using the 3D print cages. Only 6 months, you can see the fusion rate make a very sufficiently. In the 1 years, you can see the very good fusion rate in spite of the endoscope lumbar interval fusion. Also, using endoscope lumbar interval fusion, I already mentioned that the chronic adhesive disc drilling make some sufficient disc height restoration. That means that we can perform the indirect decompression can possible. It means that so many cases mild stenosis cannot need the central decompression, not need only cage insertion is sufficient to improving the patient result. And also using this advantage of chronic adhesive disc drilling, we can apply to the degenerative deformity cases like this. And also I will show some of my cases. You can see that this case is a 40-year female patient, male patient with a severe L5S1 collapsed disc that need some sufficient disc restoration and sufficient angle making the needed for L5S1. You can see after operation sufficient correction is possible. And also this another case is showing the degenerative deformity cases, failed back surgery cases. And after using the chronic adhesive disc drilling, you can see the degenerative disc is corrected sufficiently. Kyphosis is also corrected sufficiently. Also, this another cases of failed back surgery cases with complex cases with deformity and stenosis and foraminal stenosis together, all solved very easily using the endoscope lumbar interval fusion. You can see in there is not needed some removal of implant, the previous implant. Only decompression also possible, fusion also possible using the endoscope lumbar interval fusion. Also, you can see this patient, 85-year, very old male patient with the degenerative deformity, severe back pain. And after endoscope lumbar interval fusion, you can see the this corrected very well, and the patient pain disappear mostly. And also, this another cases of 70-year-old female patient degenerative deformity corrected very well. And you can see here there's some segmental angle also corrected very sufficiently using the endoscope lumbar interval fusion. Also, this another case is 77-year female patient with this patient also some medically some problematic patient with you can see the some brain surgery before. In spite of them, you can see after using the endoscopy lumbar interval fusion, you can see that it sufficiently corrected the patient uh, 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 alignment, and also then the patient pain also disappears so much. This another cases of pelvic surgery cases came to with neoplastic state after long fusion, but after endoscope lumbar interval fusion, only single level fusion thoracic area. You can see uh, after operation when the spinal alignment corrected sufficiently, and 4 weeks later, spinal alignment corrected near completely, and also 6 months later, the patient motor improved near completely, and the patient can possible walking. And this case is firstly, I show that using the endoscopy lumbar interval fusion, you can see nowadays we can only posterior with not a larger skin incision. The sufficient correction is possible, indirect decompression is possible, sufficient segmental angle making is also possible. Because of that, the patient can possible to achieve sufficient clinical results compared to the conventional open surgery. I believe that endoscopy, lumbar interval fusion and endoscopic surgery will change the next generation of spinal surgery. Thank you so much for your kind attention.
Thank you, Professor Kim, for keeping on time. We have 1 minute for questions. We open the floor for questions.
Yeah.
Anyone? Maybe I ask one question, Professor Kim. You show that you have a unilateral placement of a cage to correct the lateral tilt. Would that compromise on the fusion rate, Professor?
Can you ask about one more time?
Yeah. Some cage you put only unilateral side, one side.
Yeah. Yeah, but I understand that because of that some collapsed area is a more loading point is more forceful. Because of that, some inserted the cage that area is more sufficient to correct the force, and making the sufficient fusion rate is more good in that side.
Yeah, thank you. One from Fat. You may ask question, Dr. Fat.
Hello, thank you very much for this very interesting lectures. Please, I have one question. What do you think the role of intraoperative electrophysiological monitoring during this transforaminal approaches for the beginner and for the most experienced people? What do you think the role of electrophysiological monitoring?
Yeah, for the beginner, I think that maybe intraoperative neuromonitoring that needed, but especially in cervical and thoracic decompression cases, they need some intraoperative neuromonitoring. But in the expert surgeon, like some endoscopic lumbar operative, mostly there is not needed some intraoperative neuromonitoring. Because of that, we can sufficient already knowing the anatomy, already protecting the nerve. But anyway, I using the intraoperative monitoring will be more safe and more helpful to save the intraoperative neural damage.
To move on to the next
Okay.
speaker. Thank you, Professor Kim, for a nice lecture. Maujuba, Doctor, please.
Yes, please. We thank you so much, Dr. Kim. Thank you so much. So now we will welcome Dr. Nikolai Piv from Kingsbridge Hospital, private hospital, to tell us about OLIF. Thank you, Nikolai.
Is Nikolai here? Yeah. Good.
I'm here. Hello.
Good to see you, Nikolai.
Can you see me?
Yeah. Yeah.
Hello. Nice
Hi.
meeting you, everybody. Hi, Salman. Hi, everybody. So, do you want me to share my presentation?
Please.
Okay. Just give me 1 second. Right. Okay. Share presentation. Right. Okay. So, do you see it?
Yes.
Okay. Right. Okay. So I'll try to be also on time. Thank you so much for providing me with this great opportunity to be part of the Young Neurosurgeon Virtual Conference. I'm going to speak to you about some endoscopic approaches, and in particular, one of them. But before that, I wanted to show you This is the last AO nomenclature about treating the different endoscopic surgeries and approaches. You can see that there are quite many now already. This is constantly developing. So it's shaping nearly as a separate subspecialty now. So before I continue, I'm going to talk to you about one of the LIFs, lumbar interbody fusion surgeries. So a couple of words. Over the last year since I started, I have done big number of minimal invasive TLIFs. I do about 500-600 injections per year, which is helping me to understand the anatomy and to understand trajectories. We're gonna get there as well. And also to start, what I'm going to present to you, very helpful was that I had previous endoscopic experience, cranial and spinal, and also my uniportal endoscopic experience since 2018. So all these minimal invasive techniques are quite demanding, and we always talk about a steep learning curve. So I'm going to start with what is steep learning curve. So basically, the learning curve is steep because every time you have to jump to the next level, you have to double your cases. So we have a good research from Paulo Pereira and group that is demonstrating that you need at least 50 cases to get at about 90% milestone of a minimal invasive approach. But then the learning curve is steep because from 90 to 100%, you need another 50 cases. So 100 cases to get 100% milestone. But you really, to call yourself expert, to understand what really is happening and to master the technique, you need about 200 cases. So there is all different types of lifts, lumbar interbody fusion. So you can see on that diagram. So I'm going to talk in particular about that transcambin fusion surgery. So I'm going to touch on transforaminal because transforaminal is basically the first step of the transcambin fusion. So you go transforaminal, you don't touch the, so I just want to make clear because many people don't actually understand that. We push the cage when we are doing that surgery through the foramen, through the neuroforamen. We don't touch the bone. We don't do bony work. And that has a lot of benefits. So this is the trajectory again that I'm going to talk to you about. So this is where we are going. This is the transforaminal approach. This is that. So we are exploring that tiny space here to make it big enough to push 10 millimeter cage that is 10 millimeter wide and 34 millimeter long cage. And this is again trajectory. This is not. This is obviously a model, as you can see here, one of the upsurgeon models. Obviously, because everything is percutaneous, I cannot show you intraoperative pictures like that because simply we don't skeletonize the bones like this. But this is the trajectory we're using. This is the inferior, superior articulating facet of the inferior vertebra. Inferior articulating facet of the superior vertebra. This is the nerve root, as you can see here, and we are going just under the inferior the superior articulating facet, SAP, and we try to get inside the foramen in a perpendicular fashion to the nerve. Why is that? Because if you cross something in a perpendicular way, the crossing distance is the smallest, and like that, less chance to damage it. So we're gonna get to that a bit later, but I just wanted to make sure you understand what we are doing. We are going through that tiny space here, and we're doing lumbar interbody fusion surgery, and this is how you should imagine in the real situation. So let me play that video to demonstrate one of the cases. I'll start with that, and I will provide some explanations. This is a 49-year-old person that is previously very active, running marathons, also professionally very active. Unfortunately, she had to drop a lot of activities because of that grade 1 spondylolisthesis, as you can see here, that is causing severe radicular and back pain. And she came to see me, and then we discussed, and I have done this so-called intralift, endolift, OLL lift. So unfortunately, that procedure is still relatively new. and doesn't have a set name. People are calling it different names, so I will just continue with transcambin approach. So this is a patient that had about 1 hour surgery. The hospital stay was less than 1 day, so less than 24 hours. So it was a day surgery, and the patient had a fixation. It was all done in a transcambin approach, everything percutaneous. As you can see here, I am in the disc. Initially, you introduce a needle, then you introduce different dilators to develop the space and the disc, and then you have plenty of instruments to do discectomy and to prepare the end plates so you can promote the fusion. And then finally here you can see I am deploying the cage and expanding the cage. I am using expandable cage, and this is, you're gonna see shortly the final pictures. Very elegant and very minimal invasive, probably as minimal invasive as you can get for a interbody fusion surgery. So if you haven't, it is worth considering to start that in your practice. So it's a demanding technique. As I mentioned, steep learning curve. You need about 200 cases to call yourself master. Screw precision is always a problem, but that's not going to be the topic of the current presentation. Nerve at risk. Yeah, I'm going to discuss about that. Neuromonitoring or not. We're going to touch on this as well. Fusion rates and radiation exposure. So this is the normal pathology that is still, unfortunately, a mainstream of your training. So as a young neurosurgeon, probably you're still receiving training that is focusing in that area mainly. If you are treating one of the common surgeries that you start with when you're training when you do a spinal training, you will start with lumbar decompression, lumbar discectomies, and this is where the pathology is mostly located. And this is the bony work that you would be doing most of the time. So in order to, and this is the area, as you can see, that you can cover with this bony work. If you would like to consider endoscopic approaches, one of the main approaches that you have to learn, one of the first approaches is transforaminal approach. And this is where the transforaminal approach is focusing. So you have to go on the other side of the facet. And this is the area that you can cover. This is the trajectory that you have to go with. So it's completely different trajectory. You have to go from the other side of the facet, and that's giving you a different perspective, and you need to learn a different anatomy here because of that, although it's very close. And so you are going through the Cambin's triangle, but not even the whole Cambin's triangle. So you are addressing the lower part of the Cambin's triangle most of the times. So this is one of the most important slides that I have in my presentation, and that's one of the most important messages that I wanna pass to you today. So transforaminal approach always starts with docking your instrument. Usually that will be a needle that you will dock on at the base of the superior articulating process of the lower vertebra. So then you can slide that instrument inside the foramen, and then you slide dilator after dilator to push the nerve laterally. And also sometimes you have to, if you do fusion, you have to go inside the disc and start expanding the disc as well. And like that, you are creating the space that you need to do all the work that you have to do. So in that respect, I always like to pass that message. Lower end plate is your best friend. So everything that you do, you have to do as close as possible to the lower end plate because of that situation here. You can see that because of the obliquity, the oblique passage of the exiting nerve root, you have to do everything towards the lower end plate, because if you do closer to the upper end plate, you're facing that situation. Upper end plate, you start docking instrument right on the nerve. Lower end plate, You go inside that foramen here, inside that small triangle, and so the nerve will be staying laterally. So this is why your lower end plate is your best friend. So anything you do, a lower end plate. Another thing that I have to stress when you're starting that approach or any endoscopic approach, you have to have very good understanding of the X-ray anatomy. And this is like that because you don't have the normal anatomical landmarks like with the open surgery. Everything is on X-ray. So you have a tiny approach that you have to do everything, and you push big instruments through that. So you have to have very good understanding of the X-ray anatomy. And even more importantly, you have to have a very good understanding how to make your radiographer to give you reliable pictures, reliable X-rays. So reliable X-ray is true AP image and true lateral image. So true AP image, a few important parameters that you have to chase for every X-ray that your radiographer is giving you. So your midline structures have to be right in the middle, means that the distance between the two pedicles have to be roughly equal. And also the end plate of interest has to be in the center of your screen, and it has to be aligned, not elliptical. So if you get that, then you're reliable and you have reliable information and you can proceed further. If that's not the case, then you may think that you're at certain object, but you can be somewhere completely different. So you have to be very careful with that. Same thing with the lateral X-ray, the object of interest line, but not elliptical. Make sure that you always demand that. That's very important. So the other thing that is very important for you to understand is the biplanar awareness that you have to have, and also the three-dimensional orientation, and also the trajectory. So if you go to the courses that start teaching you on transforaminal approach, they always start telling you how to dock your instrument, where to start, where you have to put your incision. So they usually tell you L5S1, 12-16 centimeter offset from the midline, L4, L5, 11, 14, etc., etc. But it's very difficult to imagine that somebody who is 60 kilograms and somebody who is 120 kilograms will have one and the same distance from the midline. So that's why over the years, as I was doing these approaches, I tried to develop a system or rely on a system that is not based on measuring centimeters, but seeing still some landmarks. So for me, landmarks on lateral X-ray is the supraspinous line and then the suprafascital line. So everything that's in between is green. It's green because on lateral, if you dock your instrument somewhere here in that green area, you're normally okay, and you will get inside the foramen safely. Obviously, if you keep the rules that we have set earlier. So this is the same thing on axial cut. You can see that this is the green area and the red area. If you go in the red area, means if you're too low, you may get inside the abdomen, so you may cause damage to abdominal organ. If you go in the blue area, you might be too steep, and you might not be possible to get inside the foramen or even inside the disc in certain occasions in appropriate angle. So you have to stay in the green zone. If you want to go in the disc and do lumbar interbody fusion, you have to go obviously closer, more steep, close to the blue line, but not too steep. If you would like to go inside the foramen, let's say if you are addressing, let's say, paramedian disc, you have to go very close to the red zone, but try not to go so much in the red zone. This is the type of preoperative planning that I do. Normally, I will put X on lateral X-ray, where the center of the disc of interest is on lateral. And then I'll put another X where the center of the disc of interest is on AP. And then if you measure the distance between the two points, this is somewhere here. This is somewhere in the middle. And then obviously, if you would like to go more medially in the foramen, you have to go down. Or if you want to go more laterally, you have to go more towards the blue zone. And that additional line that I have here is a line that is putting you in a direction that is perpendicular to the nerve root. That's what I mentioned to you before. So when I put the center here, I go slightly up to match that line that is built so it goes below the contralateral pedicle and above the ipsilateral pedicle. So contralateral pedicle, ipsilateral pedicle. That's how you build that line.
Excuse me, Prof.
And then the rest is 3D awareness. So you start with a needle usually that you start from that point on the skin, and you start progressing your needle until you dock the needle at the superior articulating foramen initially, and then go inside the superior articulating process, and then go foramen. And these are the two lines that you have to follow: posterior vertebral line and medial pedicular line. So when you are in the foramen, you should be not medial to the medial pedicular line, and usually not further than the posterior vertebral line. And that is to ascertain that you are already inside the foramen safely, but you're not inside the dura. This is the situation that you have to face.
Hi, Nicolai.
This is the safe situation. So you are in the foramen, but you're outside the dura. This is a good situation in case you would like to go into the surgery. For example, you are inside, you are lateral to the medial pedicular line, but you're here already in the disc, which is favorable in case you would like to do lumbar interbody surgery. This is not a good situation. Here you're in a posterior vertebral line, but here you're too much inside. That means that you're inside the dura. So if you are like that with your needle, you have just done lumbar puncture with a needle, nothing bad. So, but if you don't appreciate that situation, and if you start treading the dilators and you start dilating over that key wire and then needle, you might have a problem, because you will damage the nerves and you will create a lot of issues for you and for your patient.
Sorry,
so,
Nicolai.
Sorry. For the dilators, so as I said, after the needle, you have dilators, and then you put the working cannula, and then you continue working. Couple of words about the foramen and the indirect decompression. All that technique that I'm describing, if you're doing lumbar interbody fusion, is relying on indirect decompression. And that is, I think, underappreciated and very potent technique. And the reason and my rationale behind that is that the foramen is a cylinder. And this is how we calculate the volume of cylinder. If you increase that volume of the cylinder, even with a couple of millimeters, the radius of that cylinder, which happens when you're doing direct decompression, you are basically increasing the volume significantly, and that's creating a lot of space. Promoting the fusion, you don't have anything else, so you have to put some bone promoter inside the disc. I use tricalcium phosphate, which I pre and post fill. Sometimes some of the backfilling is going back.
Are you sharing this, please?
Yes, I'm wrapping up. I think that was the approach. Thank you so much for the opportunity, and sorry if I overrun.
Majuba?
It's always better to ask forgiveness than permission.
Please, Dr. Liu, you can go on, please. Yeah.
Up for our session. Let us thank our four excellent speakers. And we move on to our next session on young neurosurgeon session. On the neuro-oncology session. We pass over to Ebuka and Manuel. Please take over. Thank you.
Sorry, I think Greg Trost is taking over. Greg?
Yep. Yeah, we're going to do a neuro-oncology session. And I won't be so nice as the last two moderators. When your time is up, your time is up. I'll just have Imad just cut you off altogether. How's that? The next speaker is going to talk about intramedullary spinal tumors, tips and tricks. And that's Keenan. Oh boy, I know I've heard him pronounce it 100 times, but Arnautovic. The co-moderator for this is Yusuf Sheikh also. So I think we'll just alternate. Okay, Yusuf?
Hello, how are you?
Good. We'll just alternate introducing the speakers.
Sure. Let's go.
All righty, let's go.
Can you hear me?
Yes. And we can see your slides too.
All right. Well, don't cut my time. I'm just starting. So anyway, I'm going to talk to the good old boring innovation in neurosurgery, which is microsurgical resection of intrinsic spinal tumors. And I'll go through a few cases. One thing that we always want to know is this sentence that the brain may forgive, but the spinal cord will not forgive. So in other words, if we do something wrong, sometimes in the brain you can get away with this, but in the spinal cord you definitely will not. So anyway, primary spinal tumors, you all know very well this ratio, but intramedullary are 5% of all spinal tumors. So they are very, very rare. And obviously, once you have them, most commonly they are gliomas, astrocytoma, and ependymomas, and sometimes metastasis and hemangioblastomas. So symptoms are very well known: myelopathy or radiculopathy, local pain in the back, especially nocturnal, and then gait disturbance, bowel bladder incontinence. Obviously, we did publish on this, and one of the most important things to know is the anatomy. Anatomy and microsurgical technique are a marriage that without which you cannot address these tumors. Other thing that is important at the closure, to use the fat graft in my hands. I'm always repeating this over and over again. I'm still waiting for my first CSF leak and first pseudomeningocele, since I've been using this technique of enforcing the suture line in the dura. Generally, we use monitoring, obviously, steroids as perioperative application, also antibiotics, and then Jackson table is very useful for AP X-rays in thoracic located lesions. And of course, division of the dentate ligament is important, as well as intraoperative ultrasound. So let's just go to the business. This is a case of upper cervical spinal cord brainstem ependymoma. And just to show some tips and tricks in the technique, obviously, once we open, we go through the midline, through the sulcus, posterior sulcus, open the sulcus widely, and expose the tumor both proximally and distally without touching or jeopardizing the posterior funiculus deep sensory pathways. Once we go down and expose the lower pole of the, once we expose the lower pole of the tumor, as you can see here, opening the pia with number 11 blade, we start decompressing. The patties protect the posterior funiculus, and we developed a nice plane between the tumor and the spinal cord tissue. Then we debulk, send some tissue for pathology, and then slowly deliver the tumor, as you can see here, completely out. This is the lower pole of the tumor. And then final delivery of the tumor is coming out. One very important thing is once we finish the resection of the tumor to look around and take all the cells of the tumor out, as you can see here, and B, make sure that you do a nice hemostasis. And by the way, I do not close the PIA and close the cavity. I leave it open, and this is the final view of the resection, putting some Surgicel, and this is the view of postoperative. This postoperative picture, and this is patient coming back for sutures. Obviously, he recovered his quadriparesis/quadriplegia very well. All right, so next case will be a case of hemangioblastoma in upper cervical spinal cord brainstem. This is also published in Operative Neurosurgery, and here we go. This is the nodule of the hemangioblastoma with underlying cyst. As you can see here, there is a big draining vein onto the brainstem, which we need to take care of at the very end, and we need to come at the junction of the PIA and the nodule. And of course, here you can see there is a small perforator that we are dissecting here. You see it here, coming off the pica, and we obviously need to preserve it because the small perforator carries significant neurological deficit if damaged. We come around the nodule, obviously you can see here, slowly dissecting it. Now we are at the lower pole, but please note that this main draining vein is left until the very end, and that will provide you bloodless surgery with fine microsurgical technique. Also note that I'm using this Yashar-Gil bipolar, the smallest tips. They have 3 sizes because you judge the size of the tips and the length of the bipolar based on the fine surgery you are doing and the anatomic structures. And here is the very end of the surgery. Here we are coming to the vein and coagulating the vein, main draining vein, and removing the tumor. As we remove the tumor, the cyst is collapsing, and as you can see here, the final picture after removal of the nodule is clear that the cyst is gone. And here is a postoperative picture. Cyst is collapsed, the nodule is gone, and the patient, morning after surgery, regained her swallowing. Remember, she came as a main complaint was inability to swallow. Another case of spinal cord hemangioblastoma at T10, you can see it here at T11 with a large cyst and then syrinx all the way up to the cervical spine. I'll just go to the most important part. You can see here dissecting the hemangioblastoma of the cauda equina nerves. Obviously, again, keeping this main draining vein till the very end. Here is the stage of dissection where we go to the lower pole of the nodule, obviously, and then dissect the nerves away from the nodule, preserving the nice plane between the cauda equina nerves and the nodule. You can see here, my chief resident is helping with gentle retraction of the nerves, and of course, the monitoring is going on. Here is the, again, progressing with coagulation of small blood vessels going into the nodule. You can see here, and then almost finalized devascularization of the lesion. At the end of the case, once we have the nodule completely dissected, we will coagulate this main draining vein and remove the nodule. Here, I'm just getting full control of 360 degrees, and here is the coagulation of the vein and removal of the nodule. This is final picture of the surgery. Here you can see removal of the nodule and intact cauda equina nerves. Conus is here, and the final picture showing post-resection cavity. Dural suture line Gel foam powder, very efficient in this hemostasis of epidural tissue. And then patient after surgery with gross total resection came for stitches. This is spinal cord astrocytoma, again, published in Operative Neurosurgery. This is a patient with this lesion that came before. You can see her fairly deeply paraparetic. Remember, this is thoracic spine. You can see the tumor here. And similar rule
We're
apply.
getting close to the end here, okay?
Okay, I'll finish this case
All right,
and I'll wrap up.
thanks.
So this is obviously the beginning of surgery, opening of the dura, also the same way, dissecting the nerve roots to see exactly where is the midline, opening of the midline with your 11 knife. PL sutures are good to open the posterior funiculus and be able to develop the plane around the tumor. And then go to distal and proximal extent of the tumor. You can see the tumor here, and then remove the tumor, as you can see here. This is the end of the surgery. I'm looking for some residual cells, which I'm cleaning, and this is the end with closing the dura. So I will just a final look how she has improved her gait after surgery. You can see her here. And I will skip the rest and just say that intradural intramedullary spinal cord tumors can be generally radically resected with no mortality and almost no morbidity. Thorough perioperative planning is important, and always microsurgery is your best bet. And this is the technique that stayed over the course of time. Spinal fluid leak and pseudomeningocele with usage of fat is the history, at least in my experience. And then patient tend to completely recover their function or at least preserve it with the use of microsurgical technique along with monitoring. Thank you.
Thanks for attempting to respect time. Yusuf, why don't you go ahead?
Okay, so next talk is by Dr. Sandeep Veshya. He'll be presenting on supracerebellar approach to falcotentorial meningiomas. Dr. Sandeep, you may start now.
Yeah. Can you see my screen?
Yes.
Okay, perfect. So I'll be talking on infratentorial supracerebellar approach for falcotentorial meningiomas. So these are very unusual meningiomas, and they comprise approximately 1% of all intracranial meningiomas. And they are generally deep-seated. By the time they present, they are quite large, and it is difficult to approach them. So there have been various techniques described, and I'll be talking about this approach alone. If you can see here, you have got a pretty good window between the cerebellum and tent, where you can directly reach the tumor without really damaging any brain structure. There are no critical structures around. The brainstem is inferiorly, and the only major critical structures are the DP system, which are surrounding the tumor. But if you are careful, then they don't really come into the play. So patient positioning, so there are various positions described. I particularly prefer to use the sitting position because it gives me a better view, and the cerebellum sags down, and so the fluid also is not pooled there. I'll just skip this. So I'll just discuss a couple of cases. This is case one. A patient presented with left hemiparesis. Is the same I showed before. And hemiparesis perhaps because this tumor is going way on one side and pressing on the brainstem on the right side. So I'll just start this video. So it is a supracerebellar approach. So it is the craniotomy is done right up to the transverse sinus. The dura is transverse sinus is here. The dura is opened up to the transverse sinus. You open the you drain the CSF by opening the cisterna magna. So, and the cerebellum, you gently retract the cerebellum to just disconnect the veins. You really don't need to actually press on the cerebellum. It is just there to prevent any injury to it by instruments. And as soon as you just retract the cerebellum and coagulate the veins, you can see the tumor right in front. So the ideal way is to just decompress the tumor. Firstly, revascularize it, and then you can see the tent edge of the tent here. This is the incisura. In many patients, you may need to cut the incisura, while in some patients, you can get away without doing that. I'll just forward this video. I don't know why it is not allowing me to forward it. Okay, so here it is because this top part of the tumor was getting difficult to reach and it was not coming down. So I cut the tent all around. That just opened the incisional opening. And now you can see it is so easy to dissect out the top part of the tumor. And once you dissect it all around, you can just take the whole thing out. So I'll just forward it further. So here I just encountered some bleeding on the right side, which was pretty difficult to control. So once I controlled it, I left a little bit tumor there because I did not want to damage the patient and just closed it. So you see, so this was the tumor. So there is one vessel going on top of the tumor. So this was small bit which was left behind. And we did the MRI after 3 months, and then you see that this tumor had grown, though it was a grade 1 meningioma. So we treated that this remaining tumor by gamma knife. This was the largest sulcotental meningioma that I had operated. This was almost 27 years ago. I think most of the young neurosurgeons here were in school at the time. And so this was more than 7 centimeters long vertically and around 5 centimeters wide. And so this was the post-op MRI. So a complete excision was done doing the same technique. And this was another patient I operated just a couple of weeks ago. This is pretty easy to operate. You see the tumor is not going too high up or not too much on the sides. It was a pretty straightforward surgery. This is post-op MRI. And so this was a lady I had operated around 12, 13 years ago. And this was one of the most challenging cases. As you can see that the tumor is going too far laterally on one side. So when it is going that far laterally, it becomes more difficult to access it. But in most cases, as you keep on decompressing the tumor, you can keep on pulling the tumor right into the view. Don't ever pull too much on the tumor because otherwise you can damage the deep venous system. And this is the post-operative MRI of the patient. And again, here again, you can see the complete excision was done. There's another lady, she was a 49-year-old female, had imbalance. She had about 10 meningiomas, and this was the falcotentorial one. And then she had a couple of big tumors on parafalcine and convexity. So first I decided to operate the convexity and the parafalcine one. And so one of them turned out to be atypical, while the other one was transitional meningioma. And so this is post-op. There was some residual disease in the sinus, and these were other tumors there. And you can see this is the post-op. And now a month later, we did the falcotentorial meningioma. And just show the video of this patient. So again, so you disconnect the connecting veins between the cerebellum and the tent, and the cerebellum sags down. And as it goes down, you don't really need to retract it. And you can see the tumor is quite avascular. Somehow, falcotentorial meningiomas are never very vascular, as compared to tentorial meningiomas, which can be immensely vascular sometimes. And this tumor was particularly quite hard. So I had to, it was not really, most of it was not coming into CUSA. So I had to use a long knife, which was almost looking like a sword, to cut the tumor in between. And part of it was soft. So you can see I'm now dissecting it from the sides after decompressing it. And so as you keep on decompressing, you can gradually mobilize the tumor from all sides. The key is to just create a hollow in between so that there is space to mobilize the tumor. So now we are doing it same thing on the right side. I'll just forward the video further. And this is the top part of the tumor that we are disconnecting from the tent. Here in this patient, I did not really need to cut the tent because the tumor prolapsed and I could remove it from there. And so this is the last bit of the tumor. I'm decompressing it with CUSA. And once you remove the last bit, you can see the ventricular contents in front of you. And now you can see that the whole tumor is out. So this turned out to be transitional meningioma. So, and this is the post-op MRI. A month later, we treated all the other remaining small meningiomas by gamma knife. And okay, so amongst the I have done about 20 falcotentorial meningiomas by this approach. Amongst the complications, one patient had a significant arterial bleeding from the tent, and I had to pack it. But every time I would go in again, it started bleeding. So we just abandoned surgery at that time. Next day, went in again and removed the tumor completely without any further problems. One patient, she was an old lady. She woke up all right after surgery. Surprisingly, the tumor was also not very big, but she worsened next day and scan showed severe venous edema. I just presumed that it was because of some venous thrombosis. We wanted to decompress. The family refused decompression, but gradually over next 3 months, patient improved to conscious state and started taking a few steps. But unfortunately developed meningitis after a few months and then remained in the vegetative state after that and passed away after a year. Two patients had pneumocephalus, which resolved spontaneously, and we did not have to do anything. Apart from that, most of these surgeries are pretty clean, except for this one first patient I showed where we had to give gamma knife. In all other patients, we had complete tumor excision. So to conclude, supracerebral infratemporal is an excellent approach for falcotemporal meningiomas, or for that matter, most pineal region tumors. Despite the size of the tumor, complete excision should always be the goal. Side effects are minimal and transient, and if there is any small residual disease, it can either be observed or treated by gamma knife. Thank you.
Thanks, Sandeep. Is Yakam on? We seen him?
Yeah, I will share his presentation. I have the recording of that.
Oh, you have a recording of it. All right. His is a keynote address about endoscopic approach to ventricular tumors. So he just sent the video in?
Yep.
All right. Well, let's have it then.
At least we know Sandeep, why Sandeep was in a hurry. He finished 2 minutes early.
Nah, nobody's early.
Students and friends. It's a pleasure for me to be part of the Young Neurosurgeons Virtual Conference, and I will present to you my idea about endoscopic approaches to the ventricular tumors. My name is Joachim Oertel. I'm from Germany, and I hope you will enjoy my presentation. This is my disclosure. I hold some patents and had a consultant contract, but everything is unrelated to this presentation. This is where I'm from the center of Europe, southwest Germany, 1 hour drive from Frankfurt, Strasbourg, and Luxembourg. Our small university campus on the upper left and our Department of Neurosurgery on the right. We do about 2,500 to 3,500 procedures in 4 theaters. We have 20 neurosurgical ICU beds and up to 74 regular beds. 300 to 400 endoscopic procedures per year, 300 to 400 MIS spine instrumented procedures per year. What is the indication for endoscopy? Minimization of craniotomy, reduction of surgical trauma of the approach, additional information at the target. Most of the transcranial approaches talk about keyhole surgery, so to reduce the craniotomy and to reduce the surgical trauma of the approach. And in endonasal, we additionally have more information at the target because we use the preformed cavity of the nose. And then transventricular, we have a combination of everything. We have a minimization of craniotomy. We have reduction of surgical trauma of the approach. We have additional information at the target. And ideally, we have new treatment options. Any lesion within or close to the ventricles is suitable for endoscopy. And we can divide the procedure in a tumor procedure to tumor biopsy, tumor resection, cyst resection, or restoration of CSF circulation. The advantage of endoscopy is that although the resolution of the optical image is much lower than with a microscope, with a naked eye, we still have a lot of information because we have a high magnification, and this results in a perfect resolution of the image. Down to some of the endoscopes, you can even see the single erythrocyte. So any lesion within or close to the ventricles is suitable for endoscopy, but bimanual surgical technique is not feasible Even minimal bleeding will distract the procedure due to blurred vision, and time is an issue. If it's time consuming, it might not justify endoscopic procedures, and we do better an open microsurgical approach. What is the endoscopic equipment? We need rigid and flexible endoscopes. We need angulated optics for inspection, and grasping forceps, bipolar, scissors, monopolar coagulation, irrigation device, and a navigation system is helpful in most of the procedures. The ideal indication is if you combine the tumor procedures with CSF circulation restoration, and the most important is the endoscopic third ventriculostomy and the septostomy, the opening of the septum pellucidum from the lateral ventricle from one side to another. The tumor procedure is tumor biopsy, cyst fenestration, or tumor resection. This is suitable in any lesion within or adjacent to the ventricular system if indicated. Determination of the approach. Lateral ventricle. Entry point is usually different from the standard precoronal burr hole. Anterior and central we do with a frontal approach. Posterior can be done with a frontal or a trigonal posterior approach. Temporal is rarely a good indication for endoscopy. You see here, this is an example of an interventricular cyst, and you can approach this via an anterior frontal approach or via a trigonal posterior approach. Third ventricle. Typical entry point for the anterior third ventricle is the precoronal burr hole. And for the posterior ventricle, third ventricle, you come from far anterior. And for the roof, you get even a bit more lateral and more anterior. So you determine the best entry point with navigation, and the limit is the foramen of Monro. Here you see 3 examples of a arachnoid cyst in the a pineal region cyst, of a cystic craniopharyngioma, and of colloid cyst of the third ventricle. Fourth ventricle is actually not very frequent. It's usually addressed with a flexible endoscope through the transaqueductal approach. Tumor procedure. What does it look like? This is a tumor procedure with a tumor in the lateral. And here you see the tumor procedure. It's a precoronal burr hole. You see the tumor. The tumor is coagulated. And then step by step in a piecemeal fashion resected with a grasping forceps. This tumor turned out to be an anaplastic astrocytoma, a metastasis of an anaplastic astrocytoma the patient was suffering from earlier, and it was completely resected with the use of the endoscope. Again, coagulation, and then after coagulation, piecemeal resection with a grasping forceps. Another example, a tumor in the third ventricle. And you see this is in a dry field technique resected with a ultrasonic aspirator. And another example of a fourth ventricle. This is a pilocytic astrocytoma in an 84-year-old lady. And this can be addressed with a flexible endoscope through the aqueduct. We go into the fourth ventricle, and then we use a grasping forceps. And in this case, it was a biopsy taken. Turned out to be pilocytic astrocytoma. You see the poor image quality with a flexible endoscope, and in this case, this patient was a little bit xanthochromic CSF. And you see then it's very difficult to have an ideal overview. These are our results for the tumor procedures. So we had 150 cases. You see most of the cases is gliomas and colloid cysts. And you see that most of the approaches were done in the third ventricle, 1/4 in the lateral, and only 8% in the fourth ventricle. It's a rather rare indication. Mean surgical time is around 100 minutes. No emergency stopping. Biopsy was done in about half of the procedures, partial removal in 29, total removal in 46, and only cyst fenestration in 9. General results, biopsy and tumors had a diagnostic yield of 100%. Bleeding is a frequent problem. No emergency stopping, but switch to microscope in 4. Solid tumors larger than 2 centimeters are not suitable, it's too time consuming, and best results in combination with CSF circulation restoration. To conclude, tumors within or adjacent to the ventricular system represent ideal candidates for neuroendoscopic approach. The neuroendoscopic approach represents a procedure of choice for cystic or small interventricular lesion, particularly when an obstruction of the CSF pathway is present. And I want to invite you to the World Spine 11 if you're interested. We have a special students corner and you can apply for participation. Thank you for your interest.
Thank you. So now our next speaker is Dr. Riba Tariq, and she'll be talking about what's new in glioma surgery. Dr. Riba, you may start your screen sharing.
Hello. So I'm Ariba, and I'm going to talk about what's new in neuro-oncology, treatment of gliomas and surgical basics. So the module is that we will understand modern glioma classification and why molecular testing is important. We will summarize current guidelines, review major therapeutic advances in glioma, show surgical technologies and strategies, and practical tips for residents and young neurosurgeons. So glioma remains biologically heterogeneous. Management depends increasingly on molecular profile, not just histology now. Extent of safe resection and appropriate adjuvant therapy still drive outcomes, but targeted therapies and novel modalities are changing our timeline and choices. What's new in classification? We know WHO CNS 5 highlights. Published in 2021, it integrates molecular markers into the diagnosis, like key splits are IDH mutant versus IDH wild type and 1p19q coordinated oligodendrogliomas. The grade is now combined with specific molecular alterations like CD, K, and 2AB. Homozygous deletions upgrade some IDH mutant astrocytomas. We also have DNA methylation profiling, which is included as a powerful ancillary method, and how it's not globally available at the moment. The classification promotes an integrated diagnosis, which combines histology along with the molecular findings, rather than just morphological diagnosis. And it's basically a layered report now. The top line gives the integrated diagnosis, followed by histological classification, grade, and molecular information. We also now use Arabic numerals like 1, 2, and 3 rather than the Roman numerals that we used to use before. The nomenclature has been revised, like glioblastoma IDH mutant has been eliminated and replaced by astrocytoma grade 4, 2, and 3 IDH mutant. If molecular testing is incomplete or unavailable, the suffix NOS, not otherwise specified, is used. And if full testing is done and the tumor doesn't fit any category, then we use NEC, not elsewhere calcified. So what does it makes? It makes important that we always request molecular panel, that is IDH, 1p19q, MGMT on surgical samples. So what are the current principal points for guidelines of glioma management? In pre-op, we still go for MRI with contrast, plus minus some advanced techniques, which we are going to review shortly. In surgery, we aim for maximum safe resection. We have intraoperative tools to increase hospital resection where safe, adjuvant therapy, almost same, and molecular testing. So what are the recent advances in glioma imaging? So this is just a revision chart. Most of the techniques, most of the imaging modalities are being used. DWI, DTI, tactography. We use it for eloquent mapping and neuronavigation. Perfusion weighting imaging. There are different types of perfusion weighting images, like susceptibility images, contrast enhanced images, and the ACL, ASL. MRS, functional MRI, APT, that is amide proton therapy, amide proton movements. We'll go to it a little bit later. 2HG MRS, that is basically a type of MRS which looks at the destruction markers of IDH metabolites. SWI in intraoperative MRI and AI radiomics. So this is the DTI or tactography commonly used. Most of the young neurosurgeons, the resident, know there are different types of patterns of DTI. This is perfusion weighted images commonly used. It can show us, differentiate us from tumor progression to pseudoprogression. The intraoperative cortical mapping commonly used nowadays with the help of functional MRI. This is the amide proton movement. It basically, amide is it basically tells us the protein content of a tumor, and the susceptibility, the movement of proton molecules or process, which help us in showing the tumor. And this is 2HG, the IDH mutant gliomas. Basically, it's a type of MRS which see a metabolite of IDH, and it helps in defining the prognosis of the tumor preoperatively. So coming towards the surgery, the primary goal in glioma surgery is still the same, that is maximum safe resection, removing as much tumor as possible while preserving the neurological function. So because we have a lot of tools nowadays, how should we approach the surgery of the patient? We should keep 4 points in mind. We should balance the extent of resection versus the functional preservation. Either it's going to change the outcome or not. We should improve intraoperative detection and shortening surgical time while enhancing accuracy. The minimally invasive surgical corridors and reducing surgical footprint, like do as minimum damage to the normal tissue as possible. Use of real-time histological or molecular intraoperative testing to guide resection if that is available. So the surgical advances that matter, these are tools that reliably improve extent of safe resection and management. We have 5-ALA, fluorescent guided resection, which improves cross-retinal resection rates in malignant glioma. However, there are still studies which shows that this does not improve overall survival. Intraoperative MRI and updated neuronavigation, which of course reduce residual enhancing tumor and give you a better corridor to go for tumor resection. Awake craniotomy with cortical and subcortical mapping for eloquent areas tumor. So again, neuronavigation and mapping and use of 5-ALA can help us in differentiating tumors and gross-retinal resection as much as possible. What is new in molecular-driven treatments? We have IDH inhibitors like vorasidenib, which is a pan-IDH1 and IDH2 inhibitors. It improves progression-free survival versus the placebo in IDH mutant grade 2 gliomas done in Indigo trials and NEGM data. It represents first targeted agent with positive phase 3 data in mutant IDH low-grade glioma. This changes option for observation versus the early systemic therapy. What else? We have MGMT methylation, which remains predictive for benefit from temozolomide in glioblastoma, important for counseling elderly and poor performance patients. What else? We have tumor treating fields. Tumor treating fields basically use alternating electric currents delivered through scalp arrays as adjunct to maintenance temozolomide for newly diagnosed GBM patients. The EF14 results showed an overall survival benefit and improved progression-free survival when added to the maintenance dose of temozolomide. So this is how it looks, and it's delivered. However, there's some consideration like device compliance. Higher usage is associated with better outcomes, and there's a cost associated with it. It causes scalp irritation. So it's still underway. What's new in immunotherapy? Currently, checkpoint inhibitors like nivolumab have not shown any consistent overall survival benefit in randomized trials of recurrent GBM, so they are not standard of care at the moment. Trials continue with combination approaches and new adjuvant strategies we should expect evolving selective roles. So you've put it together, how do you manage a glioma? It's an MDT case pathway. Step 1 should be when the patient present to you, pre-op MRI, MDT discussion with neurosurgeon, neuroradiologist, neuropathologist. Step 2 should be surgery, maximum safe resection. Again, it should be maximum safe resection, not gross rotor resection. Step 3 is reimaging, early post-op MRI, go for tissue histopathology and molecular panel testing. Step 5 is adjuvant therapy, radiotherapy, temozolomide, clinical trials after rediscussion and MDT based on histopathology. Ideally, MDT discussion should be done after the tissue diagnosis is available. Again, step 6 is follow-up, MRI, support groups, clinic. So we should encourage trial enrollment. Many meaningful advances arise from randomized trials like Indigo or vorasidenib, and set up referral pathways. Take-home message, molecular diagnostics, WHO CNS 5 are essential. Treat the tumor by biology. Maximum safe resection remains core. Use 5-ALA, intraoperative MRI, awake mapping where indicated. New targeted agents like vorasidenib for IDH mutant low-grade glioma and tumor treating fields are practical enhances. Changing for selected patient, MDT and trials are crucial. And immunotherapy is currently not the standard of care. There are some surgical tips for trainees. Thank you so much.
Thank you.
Thanks for that nice update. Our next speaker is Joe Sam, who's going to talk about gliomas, electrophysiology, and 5-ALA. We can see your slides, but we can't hear you.
Please unmute yourself.
Okay, sorry.
Okay.
Thank you very much to the organizers and WFNS and ACNS for inviting me to perform and give this talk on resection of high-grade gliomas using electrophysiology and 5-ALA fluorescence. I'm Sam Joey from Penang, Malaysia. Okay, we all want to do our best for patients with high-grade gliomas. We do mapping, we use 5-LA, we use pre-operative DTI, functional MRIs, just to help them to have a longer survival. But we are always limited by time, expertise, and of course, finance. Money is an issue, okay? Before the operation, we can always use functional MRI or the DTIs to plan our surgeries, look at what are the tracks nearby, and we can plan what tests to administer during our monitoring. They can be useful for pre-op planning, but intraoperatively, they tend to have intra-op shifts and can't be very reliable. So the other modalities that can be used during operation will be, for example, the MRI, the navigation, which we always use, ultrasounds, which is shows real-time information, but the images sometimes cannot tell clearly where the borders of the tumor is. 5-ALA fluorescence, that's what I'm going to talk about today. Of course, the monitoring includes SSEPs, direct electrical stimulation, MEPs, and ECOGs. So they're mainly divided into the monitoring and the mapping modalities for intraoperative monitoring. I would like to get the audience to remember this picture. Today's topic is mainly for 5-ALA and electromonitoring. So one side is asking you to resect more. So 5-LA shows how far resection can be pursued so that we can maximize oncological benefit. But the IONM is important to prevent us from causing neurological damage and thus lead a poor quality of life for the patient. So important outcomes, it's always extent of resection. Why? Because it's proven to show to have better overall survival. But if you cause new neurological deficit, then that benefit is of no use. This is already established and published and shown that whatever we do, the best is we do not cause new neurological deficits. The dilemmas, as said earlier. Okay, so for 5-LA, they can identify the borders, but they cannot tell the functional borders. They can tell tumor borders, but we do not know exactly where the limits are to resect without causing deficits. Okay, and as we know, the MRI enhancement is not enough to guide us because the gliomas actually extend beyond that. So many people agree that IOM is definitely needed, but is ALA really needed? So it's also a discussion about cost benefit in this case. Okay. Nowadays, everyone is trying to say that we should go for supra-total resection as far as possible. But of course, we should not cause any functional deficit. So this one, everyone knows that 5LA will light up the tumor under blue-violet light because the tumor selectively take up this protoporphyrin, 5LA and convert it to the protoporphyrin 9. Okay. Fluorescence intensity, does it help us to determine what part we can resect or not? Yes, it does. So most of the time, if it's very bright, it's solid tumor. The areas we need to be worried about are the vague areas. This vague fluorescence usually means that there's infiltrated brain there. And it is proven that motor function is more frequently found in vague fluorescence, up to 60%, than into or adjacent to bright fluorescence. Okay, why do we need electrical stimulation? Okay, because anatomical criteria is no longer reliable. Those from coronal suture, 4 centimeters, all these are not reliable because of the tumor. Okay, and there's also cerebral plasticity. Furthermore, tumors may also contain functional tissue. So maximal safe resection is no longer anatomically based. It has to be functionally based. Okay. What are the disadvantages if you use the IOM or direct electrical stimulation? It can only be used intraoperatively. You can't use it preoperatively. And there is a possibility of spread causing false negatives and false positives. It can also elicit seizures, and if it occurs, the surgery will be very complicated. Okay. Cessation of function after stimulation does not mean that the deficit is permanent, and that can cause the surgeon to be worried. How to use? So usually the 3 steps. Initially, we must find the primary motor area and protect that, or some people call it the M1. Okay. Next, after we have found the area and we have mapped it, we need to protect it, and then we proceed with the subcortical motor stimulations. So a lot of people use the threshold of 3 milliamperes. I use that for our motor threshold. And using that, the literature has said that the risk of causing a permanent deficit is less than 2%. And at the end of all the resection, we can use back our stimulator to ensure that we get back the same motor response as before we started the excision with the same current intensity. Okay, there are 2 paradigms now, low frequency and high frequency stimulation. So this is for a lot of people to debate and see which is better. But generally, the low frequency is better in language areas. And currently, more and more people are using the high frequency stimulation because there's less false negatives. Okay. So this is very important. Generally, 1 milliampere of current corresponds to 1 millimeter distance to the cortical spinal tract. That's the 1 millimeter, 1 milliampere rule. And for negative mapping, it can be considered negative if there are no responses evoked at 6 milliampere for awake surgery or 16 milliampere when the patient is asleep. So these are the muscles that are recommended to be monitored. If we get transient deficits post-op, it can be due to edema, high hemodynamic problems, or we may be facing supplementary motor area syndromes. So this is an example of a case which I have performed on. It's a right frontal tumor abutting the motor cortex. We couldn't do it awake because the patient was restless and confused. So the usual dark room performed the craniotomy. Okay. And then we can see the tumor quite clearly on white light. We routinely use ultrasound to help us with the resection. Okay, so we are looking at it just to map it. So this is, we were doing the mapping, okay, with the bipolar probe and trying to find out exactly where it is to avoid the excision of the motor cortex. So this is using the 5-ALA, and you can see the tumor is lighting up nicely. And part of the motor cortex was lighted up as well, unfortunately. So we continue
Unfortunately,
resection.
your time is short, so you should move to your conclusions.
All right. So at the end of it, we managed to remove everything except a slight portion just anterior to it. Okay, so I'll skip all this literature. Looks like generally everyone is saying that it does help. There's a synergy between direct electrical stimulation and 5-ALA. Okay, thank you very much.
Thank you, Dr. Joe. So in the last, we have an interview by Dr. Marco Fontanella, who will be interviewing Dr. Vladimir. Dr. Marco, are you here?
Yes, I'm here.
Okay.
Thank you very much. It's a great honor and pleasure to interview Vladimir Benesh, which is a master, is a myth of neurosurgery in Europe, in the world. We know him all very, very well. And I have a lot of questions to ask you. But, you know, we are living in the time of AI, of robotics, and so on. What is the real vision you have for the future of neurosurgery? What expect us the new residents will do in the neurosurgery for the future? The neurosurgery was built in neurotraumatology. Perhaps all the tumor surgery will last. And what do you think?
First thing, I must thank the organizer for inviting me and for giving me this opportunity to express myself. Marco, the question was all encompassing and difficult. What I could tell from the long experience I'm having is that somehow at the turn of millennium, we achieved a lot. We got alternative treatment like radiosurgery, endovascular, endoscopic, endonasal. And in the past 20-25 years, nothing really fundamental appeared as a new thing. But there's lots of research which I'm enthused about and which I hope that it will transform into our practical use in future. And those are neurotransplantations. You would remember the transplantations for Parkinson's. Then there are all those neuroprostheses. There were hearing prostheses going directly to the brainstem, even those going to quadrigeminal plate were used. The vision prostheses, what, for instance, my friend Pablo in Alicante is doing, they have cameras on the glasses and the 400 electrodes on the occipital lobe. And the patient is able to read the letters on the screen. The next thing is neuromodulation. We are still awaiting what will happen. We modulate for depression, for OECD and these, but all these maneuvers I've mentioned are within the lab or within the preliminary clinical trials. And I hope that these will somehow turn into the practical use, like with the use of artificial intelligence, with the miniaturization of all those gadgets and all this. So this is something I would love to see in my life, the transition into the practical use of all these science fiction modalities.
Yes, a good big change. And what about, we are talking a lot about global neurosurgery. Of course, WFNS is very involved in this. I think we can improve neurosurgery all over the world. But in the past, we did, I say this like an European, we did a lot of mistakes, colonialism of neurosurgery was, and now someone is going to repeat these mistakes, going to somewhere and trying to operate, not to teach, but to operate in a European way, in a Western way, the people, and then to come back. What do you think? How can we improve our globality? Salman is laughing.
Marco, this is directly in opposite to what I've been talking about previously, about that
Yes.
high-tech research. I've seen a neurosurgical map. I guess WFNS has published it 2 years ago. We in Europe have something like one neurosurgeon per 50 through 70,000 inhabitants. US is similar, Japan is a little more, but in Africa, there few years ago there was one neurosurgeon per 8 million inhabitants, and that's really a big problem. And our activities, as you mentioned, going there and do some surgeries is versus. What we did as when I was the chairman of the neuroanatomy committee in WFNS, we were going to underprivileged countries mostly, and we did the courses for them. And these people, they really were enthused about it. And they were well educated, but they didn't have the facilities, they didn't have time to do, let's say, regular surgery as we understand that, because they were overwhelmed by traumatology and by hydrocephalus, these two. The next step was to take these people, Europe, US, and teach them. But this is something for a very long run. This is something which will depend not only on us as neurosurgeons, but on the respective governments and condition in the respective countries. But if we somewhere should be involved more and as much as possible, it's really this is what's called global neurosurgery, which I believe is a perfect term and which is something we all should be thinking about, because how can we talk about high-tech glioma treatment, about excellent endoscopic procedures when this is available to a very restricted part of the world only?
Yes, I agree. But I think that we have a lot to learn from all over the world. I've just been in Mozambique and in Beira, where is one neurosurgeon for I don't know how many millions of people, and I'm shocked. It is a really very good neurosurgeon. Perhaps he does a lot of things better than me, and so I think we will not be alone anymore in the world. We are connected, and we are not going to be alone.
Connection. And I tell you one terrible experience we had in an unnamed country, in a city of 5 million inhabitants. We did a tumor, and the skull reaction was overwhelming. So we were unable to perform craniotomy. They had 2 bars, we broken them. We asked for Gilisol, they provided one, there was only one they had. We somehow did it, we somehow resected the tumor, everyone was enthused, the patient was doing well. But leaving the city, I realized that they have no way to perform craniotomy after our departure. And this is something unimaginable to us. And you perfectly said, right, we should learn from them as well, because they are doing something different from our ways. And it doesn't mean that it's worse. They are much better in many respects than we are.
Yes. Thank you very much. And then now, Salman, we have a lot of questions, and Vladimir Benesh is a real master. I remember as chief of the educational committee in YNS, and we were all enthusiastic of him. I'm not so young. I'm just a few years younger than you, but you are really a top master in Europe and the world. Thank you very much, Vladimir.
Thank you very much, Marco, and keep those words for my burial. You know, it's too nice that I get ashamed. Thank you very much.
Thank you. Thank you.
Thanks,
Thank you.
Vlad.
Salman.
So this concludes our session, I guess, for the neuro-oncology. And next we'll be moving on to the young neurosurgeons session. And the moderators for this session will be Dr. Chloe Chia and Dr. Ahmed Al-Jaradi. So you guys may proceed with the introduction of the
Welcome
speaker.
everyone. Welcome everyone. We will start our session of a young neurosurgery session with Dr. Abuzar Gangur from Turkey, that he will talk about the meaning of minimal invasive neurosurgery. Dr. Abuzar, please, you can start.
Hi everyone. I will talk about the what is the meaning minimal invasive neurosurgery for me. I have nothing to declare, and the meaning of minimal invasive neurosurgery nowadays is the smaller opening and using endoscope. But the core concept is much deeper than this. It is about the principle of preserving brain tissue, neurovascular structures, and overall neurological function. And what you need to perform minimal invasive neurosurgery, you should have strong mentorship and guidance from the experienced neurosurgeon, and you must develop your microsurgical techniques, and you should know the anatomy, and because of this you must go into laboratory to learn the brain anatomy. Additionally, you must stay update with the profession in the latest technological advancement, and combine of these elements, you can perform minimal invasive neurosurgery. I'm lucky I have mentors, and when you look the brain, you should see the inside, and when you see the tumor, you must localize the localization inside the tumor. And nowadays you have education material like 3D. It is easier to learn the anatomy. And when you go a supracerebellar way, you must know all these anatomy, also posterior interhemispheric way. This is the pineal region. As I said, we are lucky nowadays because we have 3D models, all these structures. It is easy to learn with 3D models. You must know all the structures before going to supracerebral level, all brain stem structures and the mesial-temporal lobe structures. And also the relation with the ventricles. And also when you go supracerebrally, the most challenging issue is the bridging veins, which just develop a technique to preserve these bridging veins. As you see, we can cut the tentorium and release the bridging veins when you go deeper. This is one of my case of mesial temporal region glial tumor. This is bridging veins. With cutting the tentorium, we can release the veins and continue our operation without damaging these structures. And this is some samples with the lesions which you can reach via the supracerebellar way, thalamus, brain stem, and also superior surface of cerebellum, pineal region, and also T2 brains. And also you must think about the opening and closing section of the craniotomies. As you see, if you use a linear incision, it is easy to close, and you can prevent this postoperative CSF fistula. As you see, we are preserving the occipital sinus, and with a linear incision, you can reach these areas with brain stem and fourth ventricle and the surface of the cerebellum. Also in retrosigmoid approach, I'm using a linear incision like this, and also always preserve the these veins, all veins in the retrosigmoid area. This is petrosal vein. And I will show some video. You must use all technological equipment. As you see, there is a brain stem tumor, and you can see all these venous anatomy, a bit complex. I think the most minimal invasive way to go to sigmoid area, but we must preserve all these bridging, all these temporal veins, petrosal veins, and its branch. As you see, there are at least 5 branches of the petrosal sinus. We dissect all these veins before going to removing the tumor. And I will show the last shape of after removal of the tumor. Also, we opened the transverse fissure of the cerebellum to preserve these veins. This is the postoperative view. You can see all veins preserved after removing the tumor. And also with this approach, we can reach any lesions located in the cerebellopontine angle. And also one challenging issue is the interhemispheric approach and the bridging veins. We are using the preoperative imaging to select our craniotomy. And also in intraocular tumor, it's a challenging issue. If you go laterally, you will have a visual deficits because of this. We developed a posterior interhemispheric transparent occipital fissure approach to preserve the visual optic graduation. And also for motor area, we are using the interhemispheric transcingulate sulcus approach to prevent any deficits. And also for coronary surgery, we are using interhemispheric transcallosal way. As you see, this is the postoperative view. And also for basal ganglia, it is important the preoperative imaging and the tractography. This was the lesion located in the globus pallidus. We removed via the anterior interhemispheric way. And also, this is the two tumor in one patient. We removed to contralateral interhemispheric way and the transcilian way, as you see. And you must use all technological equipment in the operation to perform minimal invasive surgeries to localize your tumors and lesions. There's a AVM located in the medial frontal area. And in the operation, you can use these technologies and localize your lesions. You can reach our models in the neurosurgical atlas. And you are always welcome to visit our lab in Yeditepe University in Istanbul. Thank you very much for listening.
Right, thank you very much.
Dr. Chloe.
Yep, next we would like to invite Prof. Sabino Luzzi for his talk on the approach selection in cranial neurosurgery.
Can you hear me?
Yep.
Thank you. Thank you very much for this kind invitation once again, and congratulations to my brother, Professor Gungur, that showed to all of us beautiful cases and beautiful surgery, and some concepts that I will share with you today are some similar concepts that we learned together during our training period. I just want to share some concept about approach selection in cranial neurosurgery. This is an overview. This is the microneurosurgery era, and Professor Yashagi taught to all of us how to expose the lesion, how to navigate the system, and how to, perform what we really define minimal invasive surgery. Minimal invasive surgery lies in the respectful of the anatomy, not in the size of incision, of craniotomy, or everything. And in the cases that we just saw, we saw as to go there, exploiting and taking advantage to navigate each sulcus and to go deeper and deeper inside the brain, even in the most difficult and deep-seated part to deal with. And this is an overview of what we do every day in our OR. We take advantage to exploit some natural corridors to go there, interhemispheric, sylvian, basal cistern, and everything, working around a common target that we have to keep in mind to reach the lesion. The same concept is in skull-based surgery. Skull-based surgery is exactly the same. In skull-based surgery, we remove the bone and leave the brain alone. Why? Because we don't want to retract the brain. Why? Because the brain is super delicate, and the dangerous that we can do to the brain, it's sometimes more aggressive and irreversible compared to the initial pathology. And in this seminal pivotal article by Professor Spezia that require no presentations, he talked about the quiet revolution of retractorless surgery. And we do everything to try to avoid any kind of retraction in brain surgery, in the skull-based surgery. And to do this, we use some specific approach that are time-consuming, long-consuming, and everything. And our goal is just one. In every kind of approach, the approach selection. Our goal is try to avoid any retraction of the neurovascular system, because the best retraction in neurosurgery is no retraction, as we know very well. So now some beautiful consideration about the orbit here. And we see that in the orbit, how beautiful is this anatomy in terms of representation of neurovascular structure, muscle, nerves, especially the optic nerve, and especially the central retinal artery and the ophthalmic artery. And these are a long series of the complication that comes from the eyeball compression. You see, we can have some ocular complication, orbital, periocular, functional, iatrogenic settings, and everything. And since when I was resident, everybody taught me that I should be compulsive in protecting the eyeball during non-ocular surgery, during neurosurgery, and we have some anesthesiological recommendation to avoid any kind of eyeball compression during non-ocular surgery, eye protection and positioning and everything. And we have even some guidelines coming from anesthesiological colleagues about eye protection in anesthesia and intensive care that are very important to follow if we want to avoid some tremendous complication here, and we have some preventing action, rational timing, and everything. And we start to use this kind of technique during our ORs in, extraocular surgery, just to protect the eyeball, to protect, the cornea, to protect everything. Even in paraclinoid aneurysm, we live in the era where we talked a lot about the preservation of the ophthalmic artery here. And why? Because the preservation of the ophthalmic artery is critical to avoid blindness here and to avoid the risk of ophthalmic artery occlusion. And this is one of the reasons why today we use most of the pipeline device to treat most of these, aneurysms about paraclinoid region and everything. And one of the most fearable complications is the central retinal artery occlusion. This is a case of central retinal artery occlusion here. And this is a terrible complication because the patient can be blind. Despite from all of this, today we are talking a lot about transorbital neuroendoscopic surgery, and the idea that sometimes we listen to is that we can retract the ball, we can transgress and trespass the orbit to go inside the brain and to remove almost every kind of the tumor inside the brain, at the level of the anterior fossa, middle fossa, cavernous sinus, retrofossa, even clipping aneurysm and even removing the tumor. Also in this case, for example, this is one, transorbital approach for cavernous sinus meningioma, where we see into the orbit 3 surgeons, 6 hands, and 4 instruments inside the orbit, despite the fact that everybody taught to all of us the best way to protect the orbit during surgery. And this is, the chapter from some masters of this kind of technique about the complication. And we see here some complication about what they call Tones approach, and they tell that this is the real game changer in skull-based surgery. But this is a long list of complications, and this is a variation. This is trans-eyelid supraorbital endoscope-assisted approach, and this is the patient a few days after surgery. Just to clarify, I'm not against this kind of approach. I was, among the first to, popularize this approach in treating orbital lesion. But this is very good approach, in my humble opinion, for orbital lesion, not intracranial lesion. Because in intracranial lesion, it's not a good idea going through the orbit to go intracranial for the reason that I just showed you. And this is, just some of my cases. This is anterior skull-based basal forebrain lesion. We have 2 different kinds of lesion, and the left one is a huge glioma here. And this is one of the last patients that I did, 1 month ago. And he came to my office yesterday. This picture was done yesterday at 20 days post-operative day. And this is the scar of the patient. This is the scar, the skin incision of the patient, and 28th day post-operative day. So this is for me minimal invasive surgery in terms of especially aesthetic outcome. The same for pterinal approach. I don't want to take too much time here. But this is what I want in terms of approach-related outcome from, what they call. This is for me my humble concept of minimal invasive surgery. These are 3 different patients. The first one, anterior clinoid meningioma, low-grade insular glioma, and MCA aneurysm. And in all 3 kinds of surgery of patient, it's difficult to find where the skin incision was. And the outcome of this patient was perfect, because I want to say once again, and I want to stress once again, especially for young neurosurgeons, that, the best retraction in neurosurgery is no retraction, and the minimal invasive lies not in the sites of craniotomy of the skin incision. The minimal invasiveness of any approach lies perfectly in the full respectiveness of the anatomy. And this is a sentence from Isaac Newton. It was, his reasoning shaping the foundation of modern knowledge. And Isaac Newton shocked us with this very simple concept, according to which wrong assumptions lead to wrong conclusion. So we have some wrong assumption about approach selection in cranial neurosurgery. Less approach means less invasiveness, less distance, less bone opening, less exposure, less skin incision. Less size means less blood loss, less operative time once again. But in neurosurgery, one of the most important aspects coming from one of my mentor, Professor Al-Mefti, is that less is less. I don't have, unfortunately, time to show my cases. I want to stop here, and I'm here for any kind of questions or whatever you want. Thank you so much once again.
Thank you so much. I think in the interest of time, we'll move on to the next session, but thank you for concluding on a very nice ending message. On to my colleague.
Thank you very much, Dr. Sabino Lopez. And now we move to our next speaker. We have Dr. Muhammad Sabri Gurbuz from Turkey, who will talk about remodeling of the neck and dome in cleaving aneurysm.
Thank you very much for inviting me to this nice organization. Everybody hears me, I guess?
Yes.
Okay. So my topic will be a bipolar coagulation of the neck and dome in aneurysm clipping. And this idea has already been described by Professor Yaşargil in 1960s, and we have to mention Professor Mallis, the inventor of the bipolar coagulation machine. So this is a case of posterior communicating artery ruptured one. I will show how we coagulate the aneurysms. After some regular steps of the aneurysm surgery, we reach our steps in dural opening, we open the dura, we open the sylvian fissure in an atraumatic fashion. This is, my colleagues said, this is the real minimal invasive surgery, not to injure brain, not making craniotomy much smaller. So we go in an atraumatic fashion. This is third nerve, this is internal carotid artery, this is posterior communicating artery, and this is the dilatation, a small aneurysm. This is an ophthalmic artery, quite distal to the distal dural ring. And now we come to the aneurysm. But this time, the aneurysm is small. We put a temporal clip on IC8 distal to the ophthalmic. We coagulate. We try to making a neck for the aneurysm. It is small. Then we try to put a clip, but the clip doesn't fit because it compromises blood flow to the posterior communicating artery and also the perforators. So we quit clipping it. Then again, we apply to coagulation. We use bipolar in the lower power settings and under temporary clipping. And now with single shot, the aneurysm disappears, blood flow to the posterior communicating artery. It's open. It's not compromised now, but we reinforce the arterial wall with a cotton petty, then we fix it with glue. And another patient is MCA aneurysm. Again, these are the regular steps. A swollen and red brain. We secure and we reach M1. Although it's a ruptured one, the sylvian fissure can be split with an atraumatic fashion. We go to the M1 to put a temporary clip. Open the lamina terminalis, drain CSF. We put temporal clip on M1. This is aneurysm. It's as usual, it's an irregular one. It covers the superior and inferior trunks. And this time, coagulation make us gain a few more millimeters to see the superior and inferior trunks. When we press on the aneurysm dome, we see the trunk, but it's very thin walled, as usually we see. So what we do here is we put a temporary clip, we dissect the neck of the aneurysm, as usual, and we coagulate the neck of the aneurysm. When we coagulate the aneurysm, the arising point of the trunks start to appear. Now we see the inferior and superior trunks, and we see where the clip blades will go. This and this. Then we proceed with the clip. We insert the clip under temporary clipping. Then we puncture. We secure the aneurysm. And since we coagulate the aneurysm, we see everywhere, every branch and every perforators. This is post-op DSA. And this is another patient with a big hematoma, large MCA aneurysm. We have a big hematoma, but still we can split the sylvian fissure as micro neurosurgical principles. Now this is our temporary clip. This is aneurysm. It's a large one. Now we expose the aneurysm, the trunks. We have a baby one, baby aneurysm here. Now in this position, we start coagulating the aneurysm to downsize the dome. See, it shrinks, the walls gets stronger, size gets smaller, so it's easier to control. So here, a few millimeters is enough to make the procedure easier. Then we put the clips, we remove the clips, replace the clips, then a second fenestrated one. Then lastly, we puncture the dome and it's reconstructed. Although this patient was a Glasgow Coma score of 5, 12-month post-op, the patient is improving quite good. This is an ACOM aneurysm. As usual, we put temporal clip on both A1s. We expose anterior communicating. And after exposing the aneurysm neck, to gain some space, we coagulate the neck of the aneurysm. We put the clip. We check for any remnant or residual. We see residual here. An inferiorly bulging part of the aneurysm is there. We remove the clip. We coagulate the inferiorly bulged part, and we put the clip. This is post-op DSA. And to come to the conclusion, bipolar coagulation technique is useful to gain some space for clip blades insertion. It should be done with high quality bipolar forceps. It should be done under low power settings. Irrigation is essential to prevent sticking. Temporary clipping is the key. And the neck of the aneurysm is best and safest to coagulate. The dome can also be coagulated to downsize. Baby aneurysms can be coagulated, and it makes further manipulation safer, but it should be done to the ruptured point and a calcified neck. And thank you very much for listening to me.
Thank you very much, Doctor, for this nice presentation. We move to the next speaker, Dr. Chloe.
Yep. Next, we'd like to invite Prof. Pablo Gonzalez to first talk on insular anatomy, tips for young neurosurgeons.
Hello, good afternoon from here. And first of all, I want to thank Salman for giving me the chance, and it's a real privilege to speak after some of my colleagues from what I call the Istanbul school. So I have a challenge, which means speaking in 8 minutes about a challenging topic, which is the surgical anatomy of the insula. And the other challenge is that I have to do it for young neurosurgeons, which indeed is what I am. So I will give my best to reach these standards. Let me start with this slide in which you can see 2 completely different tumors. The one in the left is an operculo-insular one. The one in the right is a left-sided, purely insular tumor. The origin of this tumor is most likely the same one, but the pattern of growth is completely different. And this is what I believe we have to understand after these 8 minutes. So in these 3 pictures, we can see the most relevant topographical landmarks of the insula, which I consider the operculi, which are covering the insula, MCA branches in the surface, and then in the depth, we will go progressively to the insular cortex, extreme capsule, claustrum, external capsule, and finally, the lateral aspect of the basal ganglia, which is the medial limit of our insular lobe. Why is it challenging? First of all, due to its deep location, it's in the depth of the sylvian fissure. Secondly, because it's covered by vascular structures, very relevant ones, MCA branches, and very close to the lenticular striate arteries, which are arising from the internal carotid artery bifurcation and from M1, but entering the rostral aspect, basal aspect of the basal ganglia, which is our medial limit indeed. It's surrounded by the eloquent opercula. It's mostly language, motor, sensory, and comprehension areas. Close relationship to white matter fiber tracts, very important one, dorsal ventral stream, as we will see later on, and the corticospinal tract. And then it's covering, the insula is covering the basal ganglia. The truth is that insula means island, but indeed this is not an island. As you can see, it's a continuum of the operculi. So let's have a look at the operculi, and these are the relevant ones. In the dominant, so-called dominant hemisphere, we have the speech, motor speech area, motor area, sensory area, and the comprehension area. So these very important cortical structures are really covering the insular surface. So if we have a look at the depth, we can see the relationship of these operculi with the insular surface. But as you can see, we have a good anterior, mostly in the frontal lobe, and temporal lobes to go into the insula through the so-called transopercular approach. So through the most anterior part of the temporal and frontal lobes, we can safely go into that. But for that, we have to identify important landmarks, which are the peninsular sulci. These peninsular sulci are completely surrounding the insula. So we have three of them. We have the anterior, the superior, and the inferior. And in between them, in the junction of them, we have the anterior sylvian point located at the junction of the anterior and superior peninsular sulci, posterior insular point, which is located in the junction of the superior and inferior peninsular sulci, and the junction of the anterior and inferior sulci are at the level of the so-called limen of the insula, which indeed is the point in which you usually find the MCA bifurcation. So this is our topographical surgical surface anatomy. Here you can see how at the level of the superior and inferior peninsular sulci, and also at the level of the anterior one, but you cannot see it in the coronal cut, we have the continuum of the cortex of the subopercular area with the insular cortex. So this is why I believe this is not an island, as you can understand. In this coronal cut, we can see progressively the different layers of the insula. So we have the cortex. If we remove the cortex, we can see the so-called extreme capsule, which is made of the short association fiber tracts of the insula itself. And this extreme capsule is also connecting T1 and F3 with the insula. If we remove the extreme, we can see the claustrum and the external capsule. And this is the limit of most of these tumors, the lateral aspect of the putamen, which is the last part after the removal of this extreme capsule, external capsule. So these are the fiber tracts that we have to be aware of on the insular surface. But if we remove all of them, including the basal ganglia, what we see is the close relationship of these three important fiber tracts. Ventral stem, mainly given by the IFOV and the uncinate, dorsal stream, mainly given by the SLF and the arcuate, and corticospinal tract. These fiber tracts are very closely related, especially in the most dorsal and ventral areas with these tumors. So this is why a good strategy, if we do purely transsylvian fissure approach, is to go directly to the central core of the tumor. But if we do transopercular, it's much better to go quite anterior and quite ventral in the temporal lobe. So then we can really skip damaging these fiber tracts. So you can see here the relationship of these important ones. About classification, we have purely insular and different combinations of transopercular or insulo-opercular. So again, this is just to show that transsylvian and transopercular shouldn't be enemies. You use the one you have to use depending on the tumor. So the tumor is purely insulo-opercular. I prefer to go transopercular. If it's purely insular tumor, especially the big ones, I prefer to go transsylvian. This, as we can see, is purely insulo-opercular, invading F3 and T1. So it's obvious that in this case, I want to do two windows, one through the frontal, one through the temporal lobe. Always I use MEPs, very, very important. I don't do awake surgery for this kind of insular tumors. So this is right pterional, frontal lobe, temporal lobe. We release CSF. We open a little bit the fissure just to get orientation about the relative location of the artery. So that's M1 and the M2s. And then we create now the windows through the T1 and through F3. Through T1, we can see already tumor there. We go to the temporal pole. And then once we reach the head of the hippocampus, as you can see there, now we go subopercular, subpial to the insula. So this is the insula itself, and we are going, here you can see the insula, we are going below the inferior peninsular sulcus. There is a moment in which it's too dangerous to go too up. So in that case, we start doing the F3, transopercular through the frontal lobe. So then we join the two approaches, and we find our surgical cavity exactly in the same point. So we have done transopercular through the frontal and through the temporal lobe in a case like this. This is the opposite one, purely insular. And you can see this sagittal cut, how the lumen insula is completely insufflated, but T1 and F3 are completely free of tumor, especially in this coronal cut. And you can see how the posterior part of the insular lobe is free of tumor. Whenever you are in doubts, just compare both sides, the healthy side and the tumor side, to see the difference in between them. Surgical anatomy, again, dorsal, ventral streams, and corticospinal tract. This is what we have to be worried about, and this is what we will be dealing in the last part of the surgery in case of Transylvian. So what we want to do is to go directly to the central core of this tumor and decompress it, and then we will extend the resection ventrally and postero-dorsally so as to find through subcortical motor stimulation the corticospinal tract. This is the strategy in most of these cases. Important to work in between the MCA branches, which in cases of low-grade gliomas are mainly in the depth of the sulci. With the echo, we can check the relative location of the tumor, and I want to show you how, after splitting a little bit the fissure, the tumor is appearing right there. You can see how the tumor has splitted the Sylvian fissure for you. Internal decompression, and at the end of the surgery, the most posterior part, we just go and start doing motor subcortical stimulation. So this is purely Transylvian, completely different, and this is has to finalize. Learn from your best teachers. So do your post-op MRI just to learn how your surgery did and learn from these complications you might have. Thank you very much.
Right. Thank you very much for a very concise presentation on a large topic. I hand over to my colleague now to introduce the interviewers.
Thank you, Dr. Paulo, for this nice presentation. Next, we have Dr. Muhammad Kustiansa. I hope that I pronounced it correctly. That he will talk about challenges in vascular surgery in low and middle income countries. Dr. Muhammad. Dr. Muhammad, we can't hear you. Please unmute yourself.
Yes, hello. Can you hear me?
Yes, now good.
Okay, thank you very much for the opportunity. I'll try to explain briefly about our experience in Indonesia. We've been doing this for 3 years. This is a historic moment in Indonesia. We try to transform cerebrovascular care, and neurosurgeon play a very important roles. This is a brief data of stroke in Indonesia. And we are a big country with 275 million people across more than 900 inhabitant islands and 10,000 islands in total. So it's a logistical nightmare. The distribution of tools and human resources are very difficult. We have 5 major islands with 36 provinces, and the current Ministry of Health is very ambitious about doing a significant transformation. This is where we are at 2021. As you can see, our number is very bad. We only have 9 comprehensive cerebrovascular center, which is a center capable of doing from thrombolysis until definitive treatment of microsurgical endovascular treatment. We only have 12 thrombectomy-ready hospital, and primary stroke center capable of doing thrombolysis are only 7 at that time. This is very dramatic, and we want to increase this number in the shortest period of time. So we have 6 key strategies. We first, we create our own hospital tier system. So comprehensive stroke center will be named an Utama hospital, which is capable of doing thrombolysis, thrombectomy, and surgical clipping. And then thrombectomy capable hospital, we call it Madhya Hospital, which is capable of doing thrombolysis and thrombectomy. And our primary hospital will be Dasar Hospital, capable of doing only thrombolysis. And we created the Paripurna Hospital, which is the highest tier of hospital system, capable of doing everything, and also have a responsibility to train another hospital to be able to do cerebrovascular services. And we also determine what kind of tools and what kind of services should be done in each tier hospital. This is, for instance, Paripurna Hospital have the most tools from imaging, microsurgical tool, and endovascular tool. Madhya Hospital at least can do high-speed, ICH evacuation, decompression. So at least they need to have a high-speed drill, neurosurgeon, or trained general surgeon. This is the system that we've been testing and implementing for the last 3 years in our country. We also create a proctoring SIM using that tier system. So the Paripurna Hospital will train Utama Hospital, and then Utama Hospital will train more Madhya Hospital, and Madhya Hospital will train Dasar Hospital. So with this tier system, we hope that we can effectively increase the number of stroke-ready hospitals in our country in the shortest period of time. We also do the mapping of each provinces. We have the 514 districts across 36 provinces. So we identify which district to prioritize for the next 5 years. This is example of Aceh district is our northern part of the Sumatran island. This is Borneo and this is Bali. You probably all know about Bali. We try to map the district using QGIS to determine which hospital to prioritize based on the golden period of 4.5 hours for thrombolysis. So the target is to create 34 Utama Hospital, which means all provinces are capable of doing clipping and endovascular treatment. And then our target is all district, which is 512 in this number, is capable of doing thrombolysis, thrombectomy, and coiling. And there will be no Dasar hospital in the future, which means all district hospital will at least capable of doing basic endovascular services. Currently, we have 9 Paripurna hospital, but we hope to increase also the number in the future. This is 9 hospital across Indonesia, and this hospital, 9 neurosurgeons in this hospital are responsible in training younger neurosurgeon in another provinces and district to be able to do cerebrovascular services. We also train, of course, the nurse and their interventionist, intraoperative nurse, and the other supporting system staff. This is where we are at the middle of our program, which is in 2024. We have 16 provinces capable of doing clipping, and we plan to increase that to 34. We create a short training program as well. This is 6-month intensive training program. We train 20 neurosurgeons from 20 provinces. It's a hybrid program of hands-on course, live surgery, and also webinars. We include all the big neurosurgeons across the world, like Professor Okuya Tanikawa, Professor Michael Lawton, and Professor Subin. And this program, for 6 months, we use innovative cerebrovascular models for hands-on training because cadaver are very, very expensive. We fly to Barrow to gain some consult about innovative neurosurgical training, and they created for us a full 3D printed head models, which is way cheaper than human cadaver. We do a training for 20 neurosurgeons. And by doing that, we increased the number of clipping-ready hospital by 34 by the end of last year. This is the proctoring SIM, which the neurosurgeons from Paripurna Hospital fly to a smaller district or province doing cerebrovascular surgery and open vascular surgery. And as you can see here, this is our Ministry of Health in white shirt. He is very supportive. He even come to the OR to see the surgery live. He come to see the patient. This is on the national news. So public relation is very important in this program to raise awareness of the public about the importance of this transformation program. So current updates, we have trained more than 1,000 healthcare workers for cold stroke. We do a dozen of case proctorings in a lot of hospital. We train more than 251 nurses in 88 hospital. This is the increase of numbers of thrombolysis, thrombectomy, and clipping ready hospital. And we also, with the government, do a short fellowship program for neurosurgeons, 6-month hybrid training of open and vascular surgery. This is the number of cold stroke activities. This is our clipping ready province now, which is 31 provinces, 3 more provinces to be trained, and there are 4 new provinces in the Papua Island that will be trained in the next 3 to 4 years. This is our thrombectomy and coiling ready hospital now. It's still a long way to go. We only have 94 districts now, which is dramatically increased from the beginning of this program in 2021, but we still have 300 plus districts to be trained to be able to do thrombectomy. And a future directive is we are increasing our fellowship locus. We already signed agreement with a lot of overseas fellowship centers. We send a lot of fellows now to another country to fulfill the quota. And this is the number of neurosurgeons in Indonesia. We only have 560 neurosurgeons, and it's only across 136 districts. So we are short 378 districts without neurosurgeon. This is the map showing where the general surgeons are. So we decide to train general surgeon to be able to do our job. I also want to show the gap. This is the gap of insurance coverage. That's why microsurgery are still very important in our country. We are doing high flow bypass, bypass for moya and bypass for cerebral aneurysm. So this is a historic moment. This is my last slide. A historic moment for our country. We tailor protocol based on our geography, socioeconomy, and cultural differences, which we believe cannot be replicated anywhere else in the world. It's us against the disease, not us against each other. This is a picture of the head of Neurosurgical College, Neurology College, and Radiology College sitting together thinking about the future of our country. So we are fighting against the disease, not against each other. Thank you very much.
Thank you, Dr. Mohammed. And we'll move with our colleague to present our last speaker of the session.
Right, so I invite Dr. Ivana Roskova for her interview with Dr. Keenan Arnautovic.
Thank you so much for the work. Good afternoon, everyone. First of all, I would like to congratulate the organizing committee for organizing this amazing event. It's a great honor to have with us Professor Kenan Arnautovic, one of the most distinguished figures in modern neurosurgery, known worldwide for his contribution to skull-based cerebrovascular spine surgery, as well as his dedication to education and mentorship. Sir, thank you so much for joining us today. We are truly delighted to have you here.
Thank you, Ivana. Obviously, we speak similar language, so dobar dan, and thank you for having me today.
Thank you, Professor. So to begin with, could you tell us, please, what first inspired you to choose neurosurgery and how your early training years shaped you as a neurosurgeon, the surgeon you are today?
So I remember 2 events probably that kind of decided that I will be a neurosurgeon. One is when I was a medical student listening lecture of the, at that time, chief of neurosurgery in Sarajevo, Professor Faruk Konjovic, who showed some picture of brain and intraoperative pictures, and I was like impressed. To me, that was unbelievable. The other rate limiting step was when I was early in residency or when I was intern, I saw a green book, big book like a Bible, called Meningiomas of Dr. Al-Mefti. And I didn't know at that time who is Dr. Al-Mefti, but I read that book from page 1 to page 400, whatever. And I was impressed how meningiomas were systematized. Every meningioma is described, approach, and I was dying to one day go and watch this great neurosurgeon. And little did I know at that time that my dreams will come true.
Thank you so much. You perform some of the most complex skull-based and vascular procedures with remarkable precision. Could you share with us, please, what guiding principles or habits have helped you maintain the level of focus and excellence in the operating room?
So first of all, you need to check your equipment. Before every surgery, go to the OR. I check my microscope. I check my scrub tech. I check her table. I check the instruments. I make sure that everything that I need is there. That's number one. Number two, I really pay attention to do preoperative evaluation of all the imaging. Every image I evaluate, the bone windows of CT scan, the MRI, the angiogram, what have you. Then be humble. I always tell myself, be humble. Don't be overconfident, because if you are overconfident, if you are, kind of aggressive, it will bite you. And then pay attention to the details, anticipate closure at the beginning of surgery, anticipate coming of anatomic elements as you progress. So these are some of my advices, first to myself and to a young generation.
Thank you so much. That's really inspiring. So can we move to another question, please?
Sure.
You've trained and mentored neurosurgeons from all over the world. And in your view, what qualities distinguish a truly outstanding neurosurgical trainee? And if you can tell us, how can young neurosurgeon maybe balance training, research, and personal life, if there is some kind of balance between all of this?
So I have, at the moment, I have 2 young neurosurgeons. In addition to my residents, we have 18, I think, residents in our program, great residents. But I have also 2 fellows currently from Croatia. When you look at the person and when you see how interested they are, you can really pick the level of their interest. Are they very interested, a little bit interested, and all that? In a way, after so many years, you can see that in their eyes. But you, younger generation, obviously, you are coming armed with knowledge about computers, about knowledge about publishing video clips, how to do the beautiful pictures, how to do illustrations. So these things all help for young generation to learn. But the most important thing is interest in neurosurgery, spending long hours with their mentors, learning at home from the books and atlases and videos and all that. So I think these are a few important traits.
Thank you. You've been also actively involved in WFNSA and all the international education programs. So how important do you think this global collaboration is in shaping the next generation of neurosurgeons?
It is extremely important. Why? Because, as you know, not all neurosurgical trainings are top-notch. Some countries don't have enough neurosurgeons to treat young generation. They don't have equipment. So what I realized early is that this bilateral visits, young neurosurgeon visiting us in first countries where there is a lot of good equipment, knowledge, eagerness to teach, and us going there and teaching them on site can bridge some of these training gaps that they may have. The other also important thing is to understand the needs, not the needs. I think Marco Fontanella, my friend, sent a few days ago. In Madagascar, the needs are different than in Sudan, in Albania are different than in Norway, So people need to understand the needs because it's very, very sophisticated to address different requirements, different needs in every country. The other thing is using seminars like this one, where young generation can see what is done, what needs to be done, which direction they need to go. Video clips that they are now available on Operative Neurosurgery, World Neurosurgery, and other places, and also kind of getting to watch on site, as I said, bilateral visits, masters, how they operate, and working in the cadaveric labs, which almost every prominent training center has.
Thank you. I think we are getting out of time, so maybe I will just go to my last questions, Professor. And what's your message or piece of advice would you like to share with young residents or consultants joining us today who aspire to follow in your footsteps?
So first of all, I would advise them to be themselves, because their biggest strength is their personality, their eagerness to learn. So do not change, no matter early in the career or late. One of the important thing is take no as an answer. Whenever somebody tells me no, it stimulates me to go around and do my plan, publish my paper. So if they send you cannot do that study, research, publish a paper, just go around. Don't take it no. Strive for excellence. Always do the best to be the best possible outcome. Of course, it's not going to happen every time, but if you don't strive for excellence, then you can accept a very good outcome. Never give up. I never give up. If they hit me with the bat, I regain consciousness and come up and proceed, because you cannot allow to be defeated. This is a tough profession. And then a few more things that I always tell my residents, and I'll close. Do the best possible boards, be board certified in American, European, African, whatever board is that you are attached. Published in best possible journals. You don't want to spend 2 months preparing an article and then publish in some journal that nobody reads. You defeated the purpose. Strive for excellence. You're not going to publish always in the best journal, but that's the way you learn to be the high-tech, high-quality publication. And the last sentence I'll say, create the network of friends, create the network of friends, be a good friend, be a good parent, be a good father, take care of your colleagues, whenever you see your colleagues, when they see you and they smile, that will be indication that you did something good. And then most importantly, take care of your patients. They gave their life to you, they gave their well-being to you. Respect that to the highest level. Thank you.
Thank you so much, Professor, for sharing your insights, experience, and wisdom with us today. It was it was such a pleasure and privilege to hear from you. Thank you so much.
Hvala vam lijepo. Thank you.
So I think that ends our session and of young neurosurgeons. And now we move on to the next session, that is doing more with less. Our moderators for this session would be Dr. Ariba Tariq and Dr. Mahmoud Qureshi. So, Dr. Ariba, you may proceed with the introduction of the speakers and then subsequently. Thank you.
So moving on, our next session is doing more with less. Our first talk is ruptured aneurysm in resource limited countries in Africa. This is a talk by Dr. Abdul Samad Al Ohabi from Morocco.
Thank you very
Dr.
much.
Samad, you can share your screen.
I already shared the screen. Is it okay? I already
Yes, Abdul Samad. Yes,
Yes,
we can hear you and we can see your scan.
Okay, thank you. Thank you for the kind invitation for this WFNS Young Neurosurgeon virtual conference. The purpose of my presentation today, since we are speaking to the young, and the young is the future for neurosurgery, I will share our experience how we develop microsurgery to treat aneurysm in Morocco, and maybe this can be used as example in other countries with limited resources. I am from Rabat, Morocco, and you can see on my slides that the cerebral aneurysm is not rare in Africa. The old common belief that cerebral aneurysm in Africa is no longer accepted. Based on one study, an autopsy study in Morocco, but also compared with what is done by other authors on autopsy study, we think that can estimate the number of aneurysms in sub-Saharan Africa of more than 8 million. Most of them, when rupture, will be not be treated either by neurosurgery, microsurgery, or by endovascular surgery, because there is a shortage of a neurosurgeon, but also there is lack of endovascular facilities in Africa. The second important thing is that cerebral aneurysm has a very high morbidity and mortality. Most cerebral aneurysms are diagnosed at ruptures 90 to 100% in Africa. The mortality is very high, 50% in the first month, and there is a higher risk of rebleeding. So there's a big burden on African neurosurgeons. The challenges for Africa are numerous. Shortage of trained neurosurgeon, neurointerventionist, and ICU bed. There is a limited access to imaging and cerebral angiography and neurointerventional equipment. The endovascular treatment requires high-cost technology, and also you know about the financial and logistical constraint in the healthcare system. So in this map, I try to show you this information regarding first the number of neurosurgeons in sub-Saharan Africa, around 370 or 400. And the ratio of neurosurgeon in Africa is 1 neurosurgeon to 2 million inhabitants. And you can see here that there are many countries with few neurosurgeons that have no endovascular team and facilities. So, in addition to this problem, we know today that after 20 years almost of developments endovascular, that endovascular treatment is not the ideal solution for many cerebral aneurysms. And for problem of durability with high risk of recurrence, there is a lower the complete obliteration rate when we compare with clipping. And there is a group of complex aneurysms that are technically demanding, and also in low and middle incomes country, the problem of affordability of devices that are very costly, and also there is no this technique is not available in most African countries. This group of complex vascular aneurysm, and you can see here, are very numerous, either because they have dysplasic wide neck or because there is some problem of vascular anatomy with accessibility, some mycotic and traumatic distal, but also some large and giant aneurysm are not very easy treated with the endovascular treatment. Most of this aneurysm are calling for the use of stent-assisted coiling and flow diverter that requires anti-platelet agent that are not safe. And as I said, in rupture aneurysm, most of the situation in Africa are rupture aneurysm. In our clinical practice, this represents around 60% of aneurysm treatment in our series. And when we compare this treatment between endovascular treatment and microsurgery, you can see here that the complete aneurysm occlusion is around 50% in endovascular, where you compare with 19% in microsurgery. And the risk of rupture is the recurrence is very high in endovascular when you compare with microsurgery. So this is the kind of aneurysm we're seeing today. They need sophisticated treatment technique with balloon-assisted coiling, stent-assisted coiling, flow diverter, and these are very costly. And you can see here that the average cost of this device is around $10,000 to $20,000 US dollar. When we compare the treatment between endovascular and microsurgery, we can see that the coiling cost 10 times clipping than the aneurysm. And the cost of implant, you can see it around 20,000 euro or dollar when we compare with around 165 units US dollar. So there's a big difference in the cost of the two techniques, in addition to the problem of the difficulty in some complex aneurysm. So how can we do more with less? how can we develop and implement microsurgical clipping in countries with limited resources? I will just share with you our experience. This is what we need currently. A minimum microsurgical instruments are needed. Angio CT, most of the neurosurgical department in Africa is available, have this CT. Micro instrument and aneurysm clip around 150 to 200 units per clip, and a microscope, and of course, good training in vascular neurosurgery is mandatory to start aneurysm clipping. So this is just to share with you our experience regarding the treatment of aneurysm rupture in our department. And we have 2 periods of time before we introduce endovascular technique in our department before 2005. And after 2005, you can see that we treated more than 1,000 cases, most of them by microsurgery. And this is very important for the young. Today, this is the best indication for either technique. Better candidate for clipping is a young patient less than 50 years, dysplasic and wide neck aneurysm, MC aneurysm, giant aneurysm, distal aneurysm, a patient with compressive hematoma and mass effect on cranial nerve. The patient that have a better result and better candidate for endovascular are posterior circulating aneurysm, poor WFNS grade, old patient with symptomatic vasospasm. And of course, there is a group patient that can be treated with either techniques, and the choice can be discussed with the interventionist. So these are to share with you some cases that we use microsurgery, and you can see on this slides that if you were to treat this with endovascular, we need this kind of devices, which will cost more than 20,000 euros. So we go for microsurgery, and we dissect the left A1, and then dissecting both A2 here, and with the fenestrated clip, tandem fenestrated clip, we use. I will skip this. So the first, and we can make this complete removal. I will maybe share with you just another case, and I will go to the conclusion, as this is a dysplagic MCA aneurysm with wide neck that has been treated by microsurgery, direct clipping, calcified sac was being opened, and the clip was replaced, and then we go to the second ACOM aneurysm in the same patient using fenestrating once again clip and another clip to totally exclude this aneurysm. So this is another case. Patient presented with large carotid ophthalmic aneurysm with effect on optic nerve, and we made anterior clinodectomy with temporary clipping of the internal carotid in the neck, and we go to the aneurysm sac. The neck was not very large. It was easy to make clipping, and then we decompress by removing totally the sac after opening the sac and decompress the optic nerve. So there are other cases that have been treated by microsurgery because the endovascular treatment was not available and very difficult in this case. And also this is a case with basilar trunk that has been treated by microsurgery. So this is when we compare our series, when we compare the cases treated by clipping and coiling, and you can see that there is no difference regarding the outcome, but there is a big difference regarding the total occlusion in clipping, more than 90%, and coiling just around 74%. So in conclusion, incidence of cerebral aneurysm in Africa is not low, and the development and implementation of microsurgical techniques for clipping is very important necessity and should be a priority. Microsurgical clipping is cost effective and the most definitive and durable method of treatment. And thank you, and I am inviting you to the 6th African Congress of Neurosurgery be held in Marrakesh in October 2026. Thank you.
Thank you, Abdul Samad. It was a very nice talk. Next is Doing More with Less by Dr. Afifa Afsar from Pakistan.
Hello, everyone. Can you guys hear me? Can you
Yes,
guys hear
Dr.
me?
Afifa. Yes, Dr. Afifa, please go ahead.
So is my screen visible to you guys?
Yes, please.
Can you guys see my screen?
Yes, we can see your screen. Please enlarge it.
Is my screen visible?
Yes, it is.
So, good evening, everyone. Today, the topic of my discussion is doing more with less. I am Afifa, and I am basically working as a senior registrar in the Department of Neurosurgery at Calcutta National Hospital. And here today would be discussing the minimal access, basically, and in the form of cranial neurosurgery, basically primarily, and we would be discussing the advent of syringe port. So basically, syringe port is basically a cylindrical tubular port hit to the neurosurgery armamentarium, and the rationale of using a syringe port is basically that we all know that the usage of tubular systems basically results in decreased and minimizing the damage to the adjacent surrounding tissues, because there's a thought that it results in equal pressure dissipation by the walls of the cylinder. So basically, we all know that this is going to result in minimal damage to the adjacent white matter tracts, and this is going to result in minimal tissue damage. Here we can appreciate that these are the most famous Y-core tubular retractors, which we know that they are basically a single use because they're disposable, and they obviously necessity is the mother of invention. So the whole concept of using a syringe port is basically, we can see in this animated diagram, is that we can access, with the help of syringe port, we can access deep-seated lesions as well as surface lesions. So the length of the syringe port can be edited and can be edited as per the direction and as per the target, the distance of the target from the surface. So in this particular animation, we can see that this is a tubular port that we can see, and it is targeting a deeper structure, which we can see here. So in our scenario, I would be basically discussing how we innovated the syringe port and how we use it in our setup, because we know that we have work in a resource limited country. So we have to tailor things according to our needs. So we devised our syringe port with the help of basic syringes, which are like 5 and 10 and 20 ml syringes. So we all know that the syringe port can be tailored as needed before the dural incision. The depth of the tumor from the level of the skin should be measured to the workstation to know the length that is required for the different syringes. And for the different lesions, the port should be long enough in order to reach to the deepest portion of the tumor along the planned trajectory. Because if the port is going to be short, so then this is going to cause difficulty with the angulation. So a shorter port will result in hampering the angulation, and it's going to result in obviously hamper the access to the margins of the tumor as well after the initial decompression has taken place. And the width of the port is also going to vary depending upon the nature of the lesion and its vascularity. So this is how we basically create the syringe port, that we're going to, depending upon the length of the target that we have, and depending upon the length of the axis that we want, we cut the syringes, and we obviously smoothen out these sharp edges. Then the front end and the back end, both of them are actually cut and they're smoothed out. Then for deep-seated syringes, what we can do is, with the front end of the metallic trocar can also be made conical in order to facilitate the separation of the white matter in a dissipated manner. And this is again one of the innovation that has been done by our friends in India, that they have made it for their regular usage. This is a metallic trocar which is conical in shape at the distal end, and they have this stereotactic system attached to the one proximal end, and this is the syringe or the tubular retractor shape that we can appreciate here. So we know that the neuronavigation tool adapters can be attached to the rear end of the trocar or the syringe flange, and or directly to the posterior end of the syringe when we are using a 10 ml syringe. So when do we use these syringe ports? So syringe ports can be used basically for multitude of lesions. You can access basically, we very commonly use them for the hematoma surgery. So it's a very frequent surgery that we perform, which is endoscopic clot evacuation. So depending upon how far seated the clots are and the various locations, we've even performed posterior fossa clot evacuations with the help of similar syringe ports. And we can also use it in the interventricular lesions as well as deep-seated gliomas. So this is the rationale and this is the thought process behind the usage, that what we do is nowadays, I'm going to share this technique further on in the further slides as well. So this is a Foley catheter that we can see here. So what we do is that we're going to pass via the syringe, we're going to pass the Foley catheter, dilate it in the distal end, and that is going to cause basically harmless dissection of the brain parenchyma. So because Foley catheter at the tip is rubber, so we know that it's not going to, it doesn't have any sharp edges. So we know this is going to cause dissection for us. And then once that tract is created, we advance the syringe further on, and then we can insert our instruments through it. So this is what has been depicted in this particular diagram. This is the technique. So this is how we do it. Here you can see that I have a syringe in my hand and we've advanced the Foley catheter. I'm going to inflate the balloon of the Foleys that can be appreciated. Once it's done, then when we're going to put it inside after measuring that if it is in accordance with the size of the burr hole, and then you proceed on further. So we'll be discussing few cases that we did with the help of syringe port. So this was a 23-year-old female who presented to us with the complaints of headache. So she had a large interventricular lesion, which was primarily in the right lateral ventricle, which was had a slight contrast enhancement, likely looked like a subependymoma because of its attachment to the septum pellucidum, which we can appreciate on the coronal as well as the axial images. This is the peroperative navigation diagram. That is how we planned our trajectory. That is slightly lateral from the slightly anterior to the coronal suture and lateral to the midline. And this was our trajectory. This was the pathway that showed that this is how we're going to enter. So that's a pre-op image. That's the surgical video that I would like to share with you guys. So here we are advancing the scope. This looked like a soft, suckable, whitish colored tumor tissue. We looked at its boundaries. Once it was coagulated, then it was debulked with the help of Kuza. This we're dissecting around it. The biopsy was being taken down.
If you move it forward, if your time is running out.
All right. So we removed it with the help of the ultrasonic aspirator. And this was our post-op picture. This was the clear surgical bed that you could see. And this is the per-operative started imaging when we went on. Then secondly, we also performed a similar case, which was an 8-year-old which presented to us with left-sided weakness. We again did it with the syringe port. So this turned out to be a high-grade lesion. Then another one, we performed another one, which was a 55-year-old who presented to us again with left-sided weakness. So there was a deep-seated lesion you can appreciate in the periventricular area. So this was also done near total dissection with a G. This came out to be GBM grade 4. And this was another one, which was in the subfalcine area. Again, it was a high-grade tumor. And this image-guided MR was basically, this is a stereotactic navigation picture from our system directly. So this was basically done on a T2 weighted image because we knew that the lesion is contrast enhancing. So these were a few cases that we performed, and thank you. Any questions?
Thank you, Dr. Afifa. Next up is Challenges in Healthcare System in Africa by Dr. Yao Christian. Kindly unmute yourself.
Thank you so much. Thank you for the invitation. Thank you for the opportunity to speak about the challenges in health system in Africa. I'm Dr. Hugues de Pono from Benin Republic. I'm working in Parakou, as is shown on the figure, and this is our hospital. And when I got the topic, I was like having a list of the challenges of in health system in Africa is very easy. Just go out there and find a list of the challenges. But if they ask me to talk about, if they don't, the WFNS young neurosurgeon asked me to talk about this topic, I believe there's something else that we need to find out about the challenges. So I was like, the first step in studying health system is to develop a definition of what constitutes a health system. So when you talk about health system, because they are two levels. You are looking for the challenges and in the health system and in Africa. So we should know exactly what health systems or what is the health system. So it's also to find out if this definition can be universal or it's only for a country or a region. And then we will find out if Africans have ever defined what a health system is or should be for them, or they just take the one of the WHO. And so what is the health system? I found out many definitions out there. Each center, many definitions out there that have been used to develop the compendium of US health system in 2016, and this has been reviewed in 2023. And each center of excellence has contributed its own definition of what is called health system. I'll give you just 3 examples. Dartmouth College Center of Excellence, they give this definition, define as a system or as an organization that consists of either at least one hospital plus at least one group of physicians or more than one group of physicians. So that's what they give a definition. The National Bureau of Economic Research Center of Excellence gave another definition also. The RAM Center of Excellence also another type of definition. The Agency of Health and Research Quality also gave the definition. We look at this WHO document report where, according to the WHO, the health system consists of all organizations, people, and action whose primary intent is to promote, restore, or maintain health. That is what is said by the WHO, and they continue by saying that this includes, for example, a mother caring for a sick child at home, private providers, behavior changes programs, and vector control campaign, and so on and so forth. So we find out also from this paper published in 2015, where they mentioned that there is a wide variety of health systems around the world, which has a main history and organizational structure as their countries. Implicitly, countries must design and develop health systems in accordance with their needs and resources. This is very important, and this is where our discussion will lay for this presentation. So each country must design and develop its own system. So we have 54 countries in Africa. If we talk about the African region of WHO, that make it a bit different. So can we find out the health system that we have in different countries in Africa? I don't think so. Many definitions led to the same purpose, but no African country definition of the health system. Leaning on the WHO definition of health system, most of the countries are just taking that definition of the WHO and using it for their own health policy. This might be the problem of where the challenges are coming from. Because if you don't take time to pull down a definition, how to define what your health system will be, I think you will face many challenges on implementation of this health system. And this author Sachs has written this document that we found. He's saying that in certain African countries, the orchestration of health system planning is decentralized with various health stakeholders. Well, stakeholders, but in other regions, a collaborative endeavor exists among government entities, labor, philanthropic organizations, and religious institutions. But the best way is to tailor the healthcare service to the specific needs for their population. If this can be done, I think we will be able to know that it's a process of healthcare planning, is an evolutionary progression, but not a revolutionary transformation. It will be ongoing, and from those way of seeing what is the health system and how to define it and all those things, we can list many different challenges, as you can see on the screen, many of them. But the main question is to know the main challenges in the health system in Africa. What are they exactly? From this our research for the corporation, we found it to be only two main challenges. First of all, we need to define and draw the African healthcare system for our population. I mean, what kind of health system do we want for our people? Will it be country level and regional level? And the second one is, what is the percentage of gross domestic products we are putting in our health system? This is very, very important because one of the most pressing issues is the underfunding of our health system. And most African nations allocate less than 5% of their gross domestic product to healthcare. This results in poor infrastructure and the frequent shortage of medical supply. So in Abuja, they outlined the Abuja Declaration that they say it is crucial to increase government funding to at least 15% of GDP in African countries. And if it's done, we will see if most countries make an effort to raise a little bit the GDP they put in health, the human resource crisis will not be there. The World Health, because the World Health Care workers are just 3% in the whole Africa, while we are having the 25% of the disease burden. So before I conclude, I will show you this diagram that the two main things I was talking about is to define self-health system for Africa. And then each country should put at least 15%, not less than 5% that it is right now, at least 15% of the GDP in each African country. And once it's done, all the different challenges that we have listed, we turn into green. There will not be any more human resources shortage. The brain drain that is happening right now will stop because when people are well paid, they are working in the facility that is well equipped, and I think they will stay in their country, and we will have more and more experts to take care of the patients and more health workers to do their job. So underfunded and fragmented health systems, human resources crisis, double burden of disease, infrastructure and supply chain deficiencies, geopolitical and economic instability are the main challenges of the health system in Africa. That is true. You've seen it all. But there is a need for African health system to have a doctrine. I mean, we need to make the right choice and underline clearly what health system we want for our population in Africa. Thank you so much.
Thank you very much, Dr. Yao. We'll now proceed to our next speaker. Needs no introduction. Professor Vladimir Benes is, as has been described earlier, a master in our profession, and he's going to show us how, through years of his practice, he can advise our young neurosurgeons to make it simple. So over to you, Vlad. It's a pleasure always to hear you speak.
Uri, thanks very much. It's good to see you. I feel very insignificant after the previous lecture because I'm going to talk about something which is, say, quite on a different level. But anyway, what life learned me is that simplicity is always better than complexity. And I'm going to talk about the skull base. Skull base surgery is, in my mind, not a subspecialty, but a philosophy or attitude. And what we need as an approach is something which is fast, which is routine, which is effective, and which is easy. Then it is obviously safe. And in all the instances, simplicity trumps complexity. In the past 30 years, I never did the orbitozygomatic approach because I never really needed. Everything which I have done, and we are department of more than 3,000 surgeries a year, was done from frontolateral approach. Basically, some 3 centimeters along the upper surface of the sphenoid bones is just enough for anything. Of course, you must have the in armamentarium craniodectomy, intra or extradural, optic canal decompression, posterior craniodectomy, and all these maneuvers, but virtually something which is on the image is sufficient. Of course, there are endoscopic endonasal, but I'm not going to talk about it. This is the frontolateral approach to the base of the skull. And from some reasons, everything is dissected, and see that you see all the vestibular tree, whatever is there, ipsilateral oculomotor, contralateral oculomotor, contralateral picon. And then from single approach, from this like 3 centimeters wide approach, you can clip as many aneurysms in the anterior or upper posterior circulation without any trouble. There are tumors which are posterior to the vessel, tentorial meningioma. Again, the same approach, the same craniotomy, the same 3 centimeters are sufficient to resect this. You need good knowledge of anatomy. We did studies on arachnoid discs looking from below optic nerve, carotid artery, distal ring. You see that there is a gap until the arachnoid starts. And this knowledge is paramount because all the tumors, most of them are meningiomas, are extraarachnoid, and all the vascular lesions, aneurysms are subarachnoid. So this is the clear border of your action. See, this is the tentorial edge, posterior communicating, and you got carotid system, crural system, and all that. And the anatomical knowledge is paramount. So just about anything supratentorial is approachable from frontolateral approach. And no other approach I did use in the past 25 years. I was always happy about that. There are exceptions, as always, like this Cavazzi approach for such a cavum-McKelly schwannoma. This is at the end of surgery. This is the view to the anterior brainstem through the cyst, and this is after the surgery. So this is some exception in that. Then we go to posterior fossa, and virtually there are 3 approaches in my hand. Supracerebral infratentorial, which I love most, retrosig, which is rarely used, and infralateral. We do supracerebral infratentorial in the sitting position, and I personally prefer exoscope because, see, with the microscope, your hands are extended, and I'm not a small neurosurgeon. I've got 180 centimeters. Even for me, this is far-reaching. With the exoscope, you have your hands flexed, you do everything with more unilateral. I never ever do bilateral approach because I want to preserve all the veins coming up from vermis. Unilateral 20 cc through the lumbar drain. This is after the opening of dura, which is modest, nearly parallel to the transverse sinus to prevent the prolapse of the cerebellum. And these are the target regions. I'm talking about the skull base, not about the pineal region. So this is the petroclival meningioma before surgery. Here it's after surgery, and see that it's rather easy. Here's the cerebellum, which is which has fallen down by gravity in the sitting position, decreasing the tumor. Here we have the internal acoustic meatus with the remnants of the tumor. So this is the lowermost target for this approach. Sixth nerve, and this is the nerve I always look for actively because damage of the sixth nerve is terrible for the patient. So here we have the sixth nerve, and here we have the fifth nerve after the end of surgery, and see that all is done from above the cerebral hemisphere. So this is very effective for everything. Beautifully, we have the anatomical correlations. See the small meningioma on the tentorial edge. This is exactly where the stitch is in this specimen. This is the ambient system with the fourth nerve, and here we have the crural system with choroidal artery and Rosenthal vein. And exactly this image we have at the end of surgery when the tumor is resected. Here is the resection. Here is the Rosenthal vein, choroid artery, and the fourth nerve. And this is the ambient system. And since the meningioma is extra-arachnoid, the arachnoid was not at all disrupted. So the whole ambient system is clean. For retrosic, it's in my hands only eighth nerve schwannoma and some exceptions. Otherwise, I do not really need this approach. So this cavernoma of the eighth nerve before and after the surgery, you see here that it's lying directly within the eighth nerve. And this was an 18-year-old boy, and the hearing improved immediately after surgery. That was very, very surprising to me. And then the last approach which I'm using is the lateral or far lateral or enough lateral, whatever you call it. It doesn't matter because the angle of approach is determined by the slope of the muscles, not by the amount of drilling. And in almost all cases, you do not need any drilling of the condyle at all. So this is disc craniotomy going across the midline because I want to have the better control. And the paramount in many instances is the drilling of the skull base, really flush with the horizontal as far as sigmoid sinus. Again, the position is the same for microscope and exoscope. Again, I prefer exoscope because I have much better angles, especially when I want to look from below up underneath my hands. So here's one of the aneurysms. This is an old case. I admit that I wouldn't do such an aneurysm again. It's vertebral junction before and after, and here the drilling is necessary, of course. But this is this hemangioblastoma arising from the lateral portion of the brainstem. It was quite a long surgery. It's worse than the AVM because when the bleeding starts, you never stop it. The patient had some cranial nerve palsies after the surgery, but he improved within 4 or 5 months, and now he's doing perfectly well. This is after the surgery. CC junction meningioma, those are the best target for this for this far lateral. And whatever you can do from above and from below the condyle, you do not need to resect the condyle at all. See the surgery here. The condyle is minimally resected. This is the C1 region, 11th nerve. First, of course, surround the enemy, then decrease the size of the enemy, cut his supply lines, and then resect the last pockets. So with all the monitoring, you find the 11th nerve, which is pushed medially towards the oblongata, and you are going then up above the tumor or along the brainstem, finding the same 11th nerve. This is some long video. I don't know how to fast forward it. But then you find the tumor from above, and the only trouble, as always, is the remaining structure here at the same side from above, and you see the same 11th nerve as that was below. The tumor itself provides the space. So once you start decreasing the tumor, you are gaining the space until the total resection. And the last is the anteriorly located structure. In this case, it is the 12th nerve, which is most endangered part of surgery. So anything you need is a lab. And even after many, many years, I really enjoy going to a lab, and I really like it because I believe that that's the first step one should take. Visit all the webinars and hands-on workshops which are available, because that's the best learning. Watching the videos, the learning for the young people now is much, much easier than we really had it ourselves, because at the beginning of my career, I probably assisted some 50 aneurysms, and I never saw one because I was holding the spatula, I was holding the cold light, and not seeing what my boss is doing inside. Now everyone can see it. And when you are seeing all the videos which are shown in all the webinars, we are all operating in the same manner. But to learn how to do that, we really need to go to a lab. And what I believe is the most important, to make it simple. So these virtually 3 approaches in my hands are sufficient for anything which is in the skull base region. All 3 approaches are routine, fast, effective, and safe. All 3 provide enough room, flexibility, and good visibility. Nothing is behind the corner, nothing is inaccessible. There are no extra risks related to the approach, which is just fine. With all those petrosectomies, you cannot avoid complications. And they are minimal invasive, because in my mind, minimal invasivity is not about the approach. I don't care about that much. I care about the approach towards or related to the lesion. And that must be minimal invasive. And that is something which these approaches provide excellently. So what we do need, it's Triple H therapy, which somehow we do not talk about much. It's humility, it's honesty, and some respect, and of course the hard work. Thank you very much for your attention.
Thank you very much for that overview to your approach. Thank you very much again for attending. And now it's time for us to get an update on the Congress of the World Federation, WFNS Congress in Dubai. And to give us that update will be 2 kingpins, the Congress President, Professor Mohammed Al-Alama, and to the WFNS Treasurer, Nasser Al-Gandor. Over to you, Ulama and Nasser.
I don't see Nasser.
Nasser is available.
Okay, then it's all on you then. It's all on you.
Okay.
Go ahead. Go ahead, Mohammed.
Hi. Happy to be I still feel myself. So I would like to Dubai first in December 1st to the 5th. We'll have also the workshops from 30th of November to 1st of December. So let me tell you a little bit about the Dubai. So
We're having some
so Dubai is number
difficulty
1.
hearing you.
Yeah, everything is clear here?
We're having some difficulty with your talk. I don't know whether it's breaking up or yeah, go ahead, please. Go ahead.
All right. So Dubai is the world's first or most cosmopolitan city. Is number 2 in safety, and also 21st happiest country in the world. When I'm talking about EU. Okay. So Dubai is located in the heart of the world. We are just 4 hours from the third population of the world, which is 5 billion. Then we are to the third nation of the world by only 8 hours. So Fly Dubai covers 36 hours, and the rest of the world is covered by Emirates Airlines, which is one of the most prestigious airlines in the world. It's very easy for most cities in the world to come directly to Dubai. The visa is also very easy to get. So we had a lot of big events here in Dubai. In 2011, we had the World Diabetes Congress with attendees were above 15,000. The World Cardiology Congress twice, 2012 and 2018, with above 10,000 delegates. And I hope we'll get WFNS again to Dubai after a few years. The biggest event was the Expo 2020 with over 25 million delegates. This is the convention center where we will have the Congress and also the workshops. And it is very easy to come there, and everything is located under same level and same plane. So it's very easy to go from the halls to the other, and also from rooms for the workshops to the others. And why Dubai is perfect as a host? We have a lot of hotels, and of all type of hotels, from 1 stars to 7 stars in Dubai, which is Burj Al Arab. All tests are available, and we have also a lot of attractions, shopping malls, Dubai Frame. We have Ski Dubai and many other attractions to read about, and please visit with your family. Let me show you this video quickly. So we will have a lot of courses and workshops from Global Neurosurgery Symposium, Skull Symposium, Peripheral Nerve, Neurotrauma, Neuroanatomy courses, and Pediatric Neurosurgery. Other states. And I encourage all the young neurosurgeons to register as soon as possible, have a seat. And also we have workshops like cervical spine, microvascular bypass, vascular CAs, spinal deformities, neurosurgery. And I would like to inform you also that we have so far 1,500 registrations, and we had over 1,200 abstracts submitted to the conference. This is beside the keynote speakers and also the plenary session speakers. So we hope that this will be one of the biggest meetings ever happened in history of neurosurgery. Please register, as the regular registration will finish at 8th or 9th of November. So you are all welcome to Dubai, and look forward to see you all there soon. Thank you.
Thank you very much, Mohammed. We're all very keenly looking forward to being in Dubai at the Congress. So thank you for that overview, and I'm sure all of those who have not yet registered will be inspired to register as soon as possible. Thank you very much again. So that brings us to the end of this particular session. I think we'll move on to the next session. Over to you, Mehmet, to indicate the way forward. But I believe that the moderators are Yahya Guvenk and Vanessa Milanese from Brazil, who are going to speak take over the next session, which is on spine. Over to you.
Thank you, Modi. And we will start now next sessions, spine sessions, with Dr. Vanessa. We will moderate. And our first speaker is Professor Mehmet Zileli from Turkey. He will present us WFNS recommendation about back pain. Please, Professor Zileli, can you share?
Yeah. Welcome, everybody. It's my great pleasure to be a part of this very nice symposia, online symposia. And I'm sharing my slides. This is about to acknowledge, to inform you about the WFNS recommendations on back pain. Actually, as you know, we classify back pain in acute and chronic back pain. And chronic pain syndromes are quite different than acute pain syndrome. And if it is after 3 months of persistent pain, of acute pain, then we need a multidisciplinary approach, psychotherapy, occupational therapy, and exercise therapy. And these recommendations do not deal with chronic back pain. Acute back pain is mostly after intense exercise or a heavy lifting. Sitting and standing are painful, and flexion is painful, and you can find trigger points. As I mentioned, chronic back pain is quite different, and then we need different painkillers, additional neuropathic component, and mobilization exercise will benefit the patients. These are some sentences about the epidemiology, etiology, and prevention. The prevalence is quite high. And we also describe the most common acute back pain reasons as ischogenic back pain, facet joint pain, sacroiliac joint pain, and myofascial pain. And as you know, there are even some other, some of them are bizarre descriptions, but many different. The fact is, the diagnostic errors of acute back pain are common, and there's no relation with pain source and radiology. I commonly give this example. This is a L5S1 ischemic disease lady at 62 years old. She described for 6 months right leg pain. But on the many people would think that fixing it at L5S1 level with interbody fusion probably would be very helpful. But the examination was showing that it is a sacroiliac joint pain, and we did a test injection. It responded, and her pain completely relieved by RF lesion of right sacroiliac joint. So this is not true that we cannot rely on radiology. And if there are red flags, we must order radiology, especially MRI. And there is strong evidence that routine imaging for acute low back pain does not provide clinical benefit. What are the red flags? Red flags we all know, and we even teach them to the medical students. In these instances, we must ask for further tests, mainly MR images. The question is, do you order MR in all low back pain patients? If there are red flags, yes. The answer must be this only. the sources of axial pain are unpredictable and no tests are necessary. Most of the patients with axial pain do not need any therapy. They heal spontaneously. And this is very important to repeat in our minds that there is almost no correlation with radiology and degenerative spine symptoms, and radiologists report lumbar disc herniation in 25% of normal population. However, if we order a radiology in all low back pain patients and we see disc herniation and we make some surgeries for those disc herniations, and we can have no pain relief, and then we will be accused by the patients that we are doing unsuccessful surgeries. So we repeat again, operate the patient, not the films. It is estimated in the United States, if they order MR images in a year, they must order 3,800,000 MR images. This study by Chu et al. Has compared two groups of patients. One group at the startup, they ordered MR images. The other group, they didn't order anything. They just managed conservatively and wait for 4 to 6 weeks. And in comparison, pain and function did not improve with early lumbar imaging. So this paper is from 2012, application of less is more to low back pain. And not imaging patients will reduce harms and costs without affecting clinical outcomes. These are role of drugs for our recommendations, then some physical therapy measures, rehabilitation, and we know that there is moderate evidence of massage and the acupuncture. Epidural injections may be helpful, especially particular steroids. Facet block or ablation, medial branch for RF lesion can help. And there is almost no role of surgery in acute low back pain because most of them resolve in 6 weeks. And how to prevent from becoming a chronic back pain? A significant portion of patients, 30 to 60%, may go to a chronic pain syndrome. And psychological evaluation and early mobilization of the patient are necessary. So as we look at the patient evaluation criteria, the radiology may be accused by unnecessary diagnosis and incidental pathologies. History taking is more important than examination, even, and more important than radiology. Ask the patient characteristics, and you must also know what the discogenic pain is, what the other disorders. In conclusion, mechanical low back pain and leg pain, diagnostic tests rarely necessary. Conservative therapies, exercise recommendations are good enough. Operate the patient, not the films, must be our logo. And seniors must make clinic and patient evaluation examination with juniors. You can find our recommendation in the Spine Committee website, and there are open access papers on acute back pain. And please visit also Education Committee website to see our regular video recordings. Thank you for listening to me.
Thank you, Dr. Mehmet Zileli, for the wonderful update on the WFNS recommendations. on back pain. And now it's my honor to invite Dr. Corina Zigos-Rakis to present about new tools in spine surgery, machine vision versus CT-guided navigation. Thank you.
Wonderful. Thank you so much, Vanessa, for the invitation, and thank you to Salman and Mehmet and the WFNS team for the invitation to speak today. Can you all see my slides?
Yes, we can.
Okay, wonderful. So my name is Karina Zigarakis, and I'm an associate professor at Stanford. These are my disclosures, which are relevant to one of the navigation technologies that I'll be speaking about today. Okay, so first of all, why should we use navigation and image guidance? So I would argue that in order to place our screws in the spine, we need the highest accuracy and high precision, because even in the absolute best and most experienced hands, bad things can happen, okay? And when we look at meta-analyses, looking at conventional freehand screws, moving to fluoroscopy-guided screws, and then 3D navigated screws, we see a significant increase in the accuracy of these screw placements, okay? In our own meta-analysis of over 50,000 screws, we found by far that CT navigation had the highest accuracy. And so I would argue that the freehand technique is like using a compass. Now we all have access to smartphones with GPS on our phones. Why would we not be using these in order to place screws with the highest accuracy when the stakes are so high for our patients? So I'll talk first about a stealth navigated guided MIS fusion technique, which can be a wonderful tool for us. Here's a patient who presented through the emergency department, 77-year-old with some medical comorbidities, including heart disease and COPD. He had a history of prostate cancer and a known rising PSA, but no known metastases. He came in with 5 days of lower back pain, progressive lower extremity weakness, and now unable to walk for the last 36 hours. Full strength in his upper extremities with some pretty profound weakness in his bilateral lower extremities, and you can see the exact distribution here. His MRI with and without contrast showed that he had some significant disease, both osseous metastases as well as epidural disease that you can see here in the lower thoracic spine. And so I would argue that this is actually a great case in a patient who is likely going to be undergoing postoperative chemotherapy and radiation to consider a minimally invasive approach. So we actually took him to the operating room for a T4 to 12 minimally invasive fusion with mini open laminectomies to get this epidural disease here. So here are the steps and some tips and tricks for stealth navigation. So you position your patient on a radiolucent Jackson frame. I open the skin with a midline incision, and then I use the C-arm to approximate the level. I'll open the midline to expose the spinous process superior and inferior to the levels of interest. So in this particular case, it's a big construct from T4 to T12. So I'm going to be placing 2 separate spinous process clamps, one at the very top and one at the very bottom. These are what some of the spinous process clamps that look like. Then we bring in our O-arm and we perform an O-arm spin. And then I'll use a navigated probe to plan stab fascial incisions for each of the levels of the pedicle. Use the bovie to get down to bone, and then use a navigated power drill to drill the screw trajectory. I place a K-wire through the trajectory, and there are many systems that now offer K-wireless MIS screw placement. However, I still like using the K-wire because it allows me to also get that tactile feedback, just like you would get with a ball tip feeler if you're doing an open screw and you can feel all of the sides of your pedicle. Use a navigated cannulated tap over this K-wire, and then I place a navigated cannulated screw over the K-wire using the navigation. And then I will also get an intraoperative O-arm spin afterwards to confirm good screw placement because you do have the tactile feel from the K-wire, but you don't have as many ways intraoperatively with MIS fusion techniques to ensure that your navigation is off. If it feels off, it probably is. So that's an important time for you to consider whether or not you need to re-register. After placing the screws in this case, perform a mini open decompression if needed. Place the rods with an MIS rod inserter. So this is really important, especially for very long constructs. You have to make sure that you have sufficient rod at both the superior aspect where you have the inserter, you always have enough rod. But at the bottom, you need to make sure you have enough rod for these big MIS constructs. So usually it'll be helpful to get an AP X-ray in order to do this and confirm that you have rod at the very bottom as well before removing your MIS rod inserter. Then, so this is actually the instrumentation portion of the procedure. And to do a fusion, we use a navigated Midas burr and then decorticate the facet joints and put in your bone graft of choice. So such as, for example, demineralized bone matrix that I'll inject. Stealth MIS cases can also be great, for example, so in trauma. So here's a patient with a 3-column fracture, and this is a really nice case where you don't need to do any decompression. So this can be done very nicely and efficiently with this MIS technique, and also a chance fracture here shown on the right. So stealth navigation, pearls and pitfalls, okay? So it can be ideal for trauma without significant compression. Ooh, and I see the countdown timer up there. Okay. So I need to go quickly. Great for hybrid mini-open separation tumor surgeries, degenerative disease with primarily foraminal stenosis that we address via interbodies. I mentioned using 2 clamps and 2 stealth stations for longer constructs like the case I showed. Optimizing clamp placement is very important. You want to be as close as possible to the region of interest, especially if you're in a mobile area of the spine, because your navigation accuracy decreases the further you are away from the clamp. It's really important for you, your resident and fellow who's operating with you, to not touch the clamp. And it's really important also to keep in mind that navigation can be off if you manipulate or retract soft tissue too much, okay? And so you need to be constantly rechecking your navigation, even in an MIS case. And there is a limit to the size of patients, even with MIS. We say it can be great for larger patients, but here's an example of a patient where all of the balls that were attached to the instrumentation to do the navigation were deep within the patient and getting bloody every single time I put them in and out of the patient. So you need to keep that in mind too in terms of what you can do depending on your patient population. Okay, 7D nav can also be a great tool. So this is machine vision technology, so different from you get a preoperative CT scan. I use this in a case of a patient who had this obviously very unstable T10 fracture. And so how does machine navigation vision work? Well, similar to the technology that you have in your Tesla self-driving car, there are actually cameras that are in the surgical light that's shown right here that's above the field. So in terms of your workflow for the 7D, you'll position the patient, you'll use your C-arm to approximate the level, and you have to perform an open exposure down to lamina and TPs with meticulous soft tissue exposure. You place your spinous process clamp near your region of interest. You have similar spinous process clamps as you do with other technologies. You bring the 7D machine over the field, remove other lights, and get a really quick flash registration that takes a few seconds. You'll select your points on the patient anatomy that align with the patient's that align with your plan. And then you've gotten a preoperative CT scan for this patient, so you don't have to bring the O-arm into the operating room. You confirm the accuracy of the registration. So this particular one is showing you all these green points that co-localize your current image to the preoperative CT scan, and that is a very good looking registration. You'll use a navigated probe to determine your screw entry point, and here you see something that's very similar to what you would see with your other systems. You can use a navigated power drill to drill your screw trajectory, a tap, and then this is a virtual K-wire because this system is actually agnostic of screw type, so you can use any brand of system. So you have a virtual K-wire that you're using now to place your screws. You can do this even in patients that have had prior hardware. So here's an example of a patient where I was able to register off of old hardware that the patient had. And I used this, and it was a nice way. I did both a fusion and then was able to see where I was when taking care of this very calcified thoracic disc. You can also do a preoperative CTA, so you can see the vertebral artery. So this is an example of using that in a posterior C1-2 fusion, and you can see the course of the vertebral arteries relative to our plan, which is another fun thing that you can do with 7D navigation. Okay, it's ideal for open cases where large open decompressions are needed. It can be used nicely for unstable spine fractures. I'm running out of time, so I'm happy to take any questions, but this requires meticulous bony exposure with soft tissue removal and suctioning of any blood in the field, really paying attention to lighting and shadows during the flash. You have to optimize your point picking, and I could do a whole 10 minutes just talking about that, and we talk about it in the OR every day. It doesn't work as well for like 1 or 2 level lumbar fusions because of how much shadowing there is for your registration. And it's also important to keep in mind that it's a different line of sight. The camera is directly over the field. So when you lean in to see something, you or your assistant can inadvertently block that. So that's very important. We'll go really quickly here, but basically 7D can have improved workflow. You don't have to get an intraoperative O-arm spin. It's really easy to get a repeat flash registration if you move the clamp. It just takes a couple of seconds to do that. You don't have to get another spin. And so this allows for some decreased intraop radiation exposure for the surgeon is really important and the entire surgical team, just like you have with some of the other technologies. But it doesn't currently work for MIS, and you really need to have great bony exposure. So in conclusion, I believe that navigation is becoming the gold standard. Different navigation platforms have specific advantages and disadvantages. Machine vision image guidance can improve intraoperative workflow and decrease radiation exposure in the majority of open posterior spinal fusions. But CT-guided navigation, at least for me, still remains the preferred MIS workflow, and these are really important tools to have in your armamentarium. So thank you very much.
Thank you so much, Dr. Zigourakis, for these brilliant sum up of these new tools. And for the sake of time, we are going to continue. Now I'd like to introduce Yahya Güvenç, a neurosurgeon from Turkey. He's going to present about doing more with less in deformity. Thank you, Professor Yahya. Oh, we cannot listen to you.
Yes, I will.
Okay, now we can.
Yes, I will start again. Hi, friends, and I will present doing more with less in deformity. And I will present only 3 cases in this presentation, and I will try to do the philosophy of deformity only because limited time. In deformity surgery, we need to know anatomy and knowledge about to do each patient deformity, and we should know wonderful knowledge about biomechanics, and we need to know spinal parameters, classifications, and surgical techniques. Anatomy, biomechanics, and surgical technique is very important for making a minimal invasion for deformity. Sagittal balance affect all of the spine, and if you perform an operation in lumbar area, it affected the thoracic area and cervical area. We should know this, and we should know whole of the spine, and we should know global spine, and we make a plan according to all of this balance. And we need to make some planning before operations, and we need to use some applications, and we put some preoperative scoliosis graphic, and we need some planning, some osteotomy, and we need to calculate to the angle of to the lumbar lordosis, thoracic kyphosis, and we need to make according this plan. And we need to know osteotomies, for example, pontosteotomies and Smith-Patterson osteotomies and pedicle subtraction osteotomies, and we need to know VCR. If we know this osteotomy and if we know which area we need this osteotomy, we can make less surgery. And I will give some examples. And sometimes we make only decompression for deformity surgery. And we look at the patient. If patient's scoliosis curve is under 30 degree and subluxation is very limited, and only patient has radicular pain, we need to make only foraminectomy or laminectomy. This is the examples. This patient have coronal imbalance and sagittal scoliosis, and this patient, balanced patients, there is a coronal scoliosis angle 27 degree, thoracic kyphosis 72 degree, but this patient is balanced, and this patient's neurological examination has only left leg pain. For example, this patient has A3 radiculopathy and monoparesia. We perform this patient on foraminectomy. We don't put any instrumentations, and this patient after operation, she can walk very well. And because of that, planning is very important. And sometimes in deformity surgery, we use only limited area instrumentations, and we should know again about the balance. If patient have balanced, but there is only limited area, listhesis or imbalanced area, we can make only short fixations for operations. If curves is again under 30 degree and subluxations over 2 millimeters, and the patient has only radicular pain and back pain and no deformity symptoms or no thoracic hyperkyphosis, again well balanced, we operate only limited instrumentation. For example, this patients operated only this area. We make some foraminectomy and laminectomy. We instrumentated only lower back, and we get balance again, and she is well after operations. And knowledge is very important. For example, this is scoliosis cases. This is 2 years old. This is congenital scoliosis. If we follow up this case on the brace, it will be grow up. And maybe these patients come to the approximately 80 or 90 degree when this patient's 30 and 14 years old. Because of that, we should know this is growing deformity, and in this age, after 3 years old, we perform only hemivertebral, less surgery. Only we can remove this red area, and we can make short fixations. Again, we can correct this deformity. And we follow, for example, this patient's approximately 5 years, and this is now it's good, and deformity is corrected, and there is no progressions, and we will remove this fixation when he is maybe 14 or 13 years old. Because of that, this is very important. Knowledge is very important. Which kind of deformity need which kind of operations, we should know very well. And anatomy is very, very important. If you know very good anatomy, we can change to the all of the operations. So I will give again a case presentation here. There is a 15 years old patient. He has neuromuscular scoliosis and genetic diagnosis and muscle disease. And I will COP angle is 171. This is from 2018. COP angle only 21 degree. 1 year later, 38 degree. Then 82 degree. We offered to do him an operation, but this year's pandemic years, and his patients didn't accept it. Then he came to us again with 171 degree, very severe degree, and some pulmonary disorders. And this is the problem if thoracic area. This is ileum. Ileum go inside to the thoracic area, and I will show this is perioperative. In this case, we can't use spine navigation. We use sometimes spine navigation. We haven't robotic devices, but we can use spine navigation. But in these patients, spine navigations don't work because vertebra overlapped to the each others, and we can't see in CT scan, and we can't see in spine navigation. And this is only fluoroscopy, and we can selections to the level with fluoroscopy. I put this case because technological device didn't work in peroperatives. So we need to know anatomy knowledge. And all of the surgeon must know very well anatomy knowledge, because during operations it can be changed. And this is during operations, and we are trying to use freehand techniques, and we put all of them, and I'm positive. And this is post-operative, and I will pass. All of this degree is good. All of this area. This is post-operative, and this is post-operative third years. There is no any complications after third years. And as a conclusion, target is very important. We should keep neurological status, we keep balance, and we are trying to doing less surgery in deformity surgery too. We should know anatomy very well, and we should biomechanic very well, and we should know surgical techniques in cadaver studies and sometimes fellowships. And we have next year 2 conferences. I want to invite Istanbul Cadaver Course and Asia Pacific Cervical and Spine Society again in Istanbul. Thank you.
Thank you, Professor Yahya Guvenk. We are for this great presentation. Now I'd like to invite Dr. Michael Lumintang. He's going to present about ACDF, or posterior foraminotomy. Welcome. Dr. Michael, we cannot listen to you. Yeah.
Okay, you can hear my voice now?
Yes, now we can.
Okay,
Thank you.
Okay, thank you so much. It's an honor to be a part of this symposium. I would like to thank to Professor Salman Sarif and Professor Yoko Kato, and to all committee and from WFNS, YNS, CNS, and for the opportunity to share. I have no conflict interest. I come from Siloam Hospital, Indonesia, with the Center of Excellence of Neuro and Neurosurgery. This picture is from Siloam Neurosurgery team from 41 hospitals spread across Indonesia. We already serve Indonesia for 20 years for now, and thank you for the support from all teams. My institution is come from Medan, a western part of Indonesia. So I mainly do brain tumor and skull-based tumors and start endoscopic surgery. But today I'm already give from the committee topic about spine. For doing more and with less, I'm gonna talk about the choosing the right path, ACDF or posterior foraminotomy. So here is the example case of patient was treated with ACDF. ACDF started in 1950. The pioneer
Sorry,
like Robinson
we
and
cannot see a slide. There's only one
oh
slide and it's not moving.
oh it's not moving. Sorry.
Yes.
Maybe sorry. Oh, okay.
We just saw the disclosure.
So did already? Okay. Now
No, I think you have to double click to.
double click. Sorry. I'm sorry to.
No, that's okay.
Okay. Now
It's loading.
Yeah, we cannot see yet.
oh, I'm sorry. Maybe I have to wait. Sorry.
Close and open your presentation again, okay?
Okay. Sorry. Where is the
Now we can see.
now you can see. Wait,
Oh.
sorry. Okay, now you can see my slide.
Yes.
Okay, sorry for okay. Today I was given topic to spine for doing more with less. I'm gonna talk about choosing the right path of ACDF and posterior foraminotomy. And here are the example for a case of patient was treated with ICDF. ICDF started in 1950. The pioneer like Robinson, Smith, and described how to decompress the spine using the anterior approach. Use the bone graft for fusion, but ICDF is an effective procedure to remove the damaged disc through anterior approach using gates and fusion. So how about the PCF? PCF, the posterior cervical foraminotomy, is the minimally invasive surgery performed from the back of the neck to relieve the pressure on the spine nerve by enlarging the neural foramen by preserving the spinal motion without fusion. Both procedures effective treat a single level of cervical radiculopathy caused by disc herniation or foraminostenosis. The clinical studies demonstrate that 70%, 75% to 90% of patients achieve good to excellent outcome with no significant difference in overall satisfaction between two approaches. For arm pain relief, both technique effective relief radicular arm pain. From the study facet trial show that PCF worked just as well as ASCDF for arm pain relief after 1 year. For the neck pain, both techniques also provide strong long-term relief from the neck pain, but the PCF may cause more neck pain for the first few weeks after surgery due to muscle pain. But this pain typically goes away about 6 weeks. For motor and sensory improvement, there is no significant difference in motor and sensory recovery between both approaches. The patient experience significant improve in their neck function and the quality of life as measured as many tools like NDI and AQID. For overall success, FAST trial 2023 reported that 88% succeed with PCF, first 76 until to 81% with ACDF at 1 and 2 years. For overall complication, both techniques have similar overall complication rate. It's about 3 to 7%. ACDF have risks such as difficulty swallowing, temporary voice issues, and injury to the esophagus or blood vessel. PCF may lead to the nerve injury, C5 palsy, but it's very rare, inadequate decompression, and instability if we remove too much bone. About infection risk, some studies show that a significant, slightly higher risk in PCF. How about the reoperation rate? Reoperation rate is very low for both technique. It's around 4 to 6% within 2 years, but PCF patient may need additional surgery, undergo the nerve compression. PCF has a lower risk issue about the adjacent segment issues. How about the operation time and the blood loss? Posterior foraminotomy is usually quicker surgery, requiring less time and the blood loss than ACDF. For the hospital stay, PCF patient typically have shorter hospital stay, averaging 1 to 3 days, compared to ACDF 2 to 4 days. Because ACDF has segmental fusion, it has higher ASD rate. It's about 20 to 30% at 10 years. In contrast with PCF, although for natural motion, since it doesn't involve fusion, PCF more cost effectively compared to ACDF. So this is the indication and the selection consideration between ACDF and PCF. Patient selection, ACDF is preferred for larger disc herniation, bone spur on the spinal cord, curvature issue, and multiple level problem or significant disc collapse. PCF is effective for localized disc herniation or bone spur. It's fit for younger active patients who want to avoid fusion. So this is the simple summary, the table, how to choose between ACDF and PCF. So this is the example case for multiple compression with kyphotic curve, but it's also good candidate for this arthroplasty. We choose ACDF for this patient. Here the example, the patient was treated with MIS, minimal invasive posterior cervical foraminoplasty. So we saw here there is compression on the right side of the nerve, C6 to C7. So now we did the minimal invasive posterior foraminotomy by tubular approach. We can do two with endoscopy. So after finish with bone wag, we goes through the axilla of the nerve root. So now we see we are removing the disc protrude from the axilla of the nerve root. So this is the final view. So for the Caucasian, ACDF and PCF both relieve cervical radiculopathy symptom effectively with no significant difference in pain relief, recovery time, and long-term function. Recent evidence suggests that PCF is an effective and cost-efficient alternative to ACDF when appropriate. Thank you for the giant already contribute to my growth. Thank you so much.
Thank you very much, Dr. Lomingtang, for this great explanation. And now I'd like to invite Dr. Christian Gragnaniello. He's going to present about innovation and new solution to difficult old problems. Welcome, Dr. Christian.
Hi, sorry, I was a problem unmuting. So thank you, Dr. Milanese and the committee for inviting me today. It's such an honor to come and talk to you at this very important meeting. What we're going to show today is a kind of a new look at all problems, and you know, offering simple solutions where solutions are otherwise very complex. So I'm going to show a case here, and first just introducing the problem itself. Usually, you know, in the lumbar spine, when we have disc herniations, most times we need to do nothing unless there is a coda equina, and only a few end up getting any operation as this spontaneously is resolved. Over time, there's been a great number of approaches that's been developed depending on where the problem is and what the instrumentation and technology is available. So I'll start with this case of a 65-year-old male that presented with classic L5 pain with some weakness. This presented somewhere else at a different institution. ASM at the time was okay. You can see here a sagittal and axial T2 MRI where the patient had some right-sided disc herniation, both compressed the foraminal and passing nerve root. At this point, the patient got a microdiscectomy, went to work really happy without symptoms, but returned again after 2 months. Patient was again treated conservatively by this physician, and unfortunately he failed. At this point, the patient, being very active, preferred to undergo a fusion, and this is what was done at that time at this outside institution. So an L5-S1 TLIF that you know, at the time kind of looked okay. There is some end plate violation by the cage, and we can see on the last panel on the right, that's the other side. So everything kind of looks good. The patient goes back to work again. Very small, very minimal back pain, no leg pain, but then again comes back 6 months after that, and now has pain again, and now has a weakness of dorsiflexion. So at this point, the patient presents to us, and we get some scans, and this is what we find. We find a cage that completely subsided into the end plates, and there's no bone growth anywhere, if not behind the cage. So confirming our suspect of an heterotopic ossification there. And this is compressing and dislocating L5. So this is very complicated to revise. The cage goes across midline. So the revision of a TLIF at the index level in this case prevents us from placing a cage on the other side or doing anything that it's like truly small. So we decided to come from the front and take that cage out. So we do an airlift, we chisel that out. We go from the back, we replace the screws. We try to get in front of the thecal sac and the nerves to drill out that heterotopic ossification, but unfortunately, there's very tenacious scar. So, we do as much of a total facetectomy as we can. The nerve appears free, and patient at this point wakes up well. Somehow, all of his pain and weakness are gone, and he does well for 18 months. At this point, he comes to my office and says, when I walk a long distance, I feel like my foot starts becoming weaker. So at this point, we do another scan, and we do also an MRI, and we see that really what's going on is that the heterotopic ossification has not changed, but there is a lot of scar in that foramen. So at this point, we're faced with a very tough choice, and some people will say do nothing. You cannot go through the scar from the back anymore. Coming from the front at this point is not possible. We're the L5S1. We don't really have many other options. So fortunately, about 18 months ago, in our institution, we started doing endoscopic spine surgery. And so we thought, what if we can get 2D foramen from the side and do a foraminoplasty and remove the scar and drill out the aberrant bone, the heterotopic ossification. And so that's what we did. And as you all know, it can be tricky to get past the iliac crest at this level. Fortunately, we were able to do so and place our cannulas and working channel directly where the pathology was. And this is a postoperative CT from our drilling and opening of the foramen with drilling of the heterotopic ossification. Again, patients did really well at this point. And so this is kind of one of those cases where there are lots of things that have happened, and you don't have really many simple options. And sometimes, technology, it's true that a fool with a tool is still a fool, but sometimes having utilizing the right tool with kind of a alternate approach can really bring you to very good results, like in this case. And I think I only have a couple of minutes left. So I know the endoscopic transforaminal route has been widely discussed today. And I'm so happy to see there are so many masters around the world that are embracing this technology. Just to say a few things about the route itself. So it's very important, the targeting, as we know, targeting becomes more lateral as we go down the spine. And it becomes very tricky when we go at 5.1. And this is what I wanted to show from a paper that was published last year, where the entry point at this point and is not really a number of centimeters, but it's made by finding the iliac crest line and taking X-rays to confirm that and coming down that direction, down the SAP. Instruments are the same. The question remains, why bother with something that has a very steep learning curve? These are just a few reasons. I think there are many, many more, including the fact that the patient goes home the same day with very minimal, if any, tissue disruption. This is really where we're trying to go. So this is a sagittal MRI. We can see that the nerve sits happily in fat at the top of the foramen, and the SAP is the bottom with the place which is where we target, or that's if we want to do trans-SAP, or more posterior, as it's been illustrated earlier, when we want to get to the disc itself. And we're able to do a foraminoplasty, increasing the space, freeing up nerves, taking pathology that also goes behind pedicle and many other things, including fusion, from this very interesting route. And this is all I got for today. Thank you so much for having me.
Thank you, Dr. Gragnaniello. Now it's my honor to invite Dr. Nargisa and Dr. Ariba Tariq to moderate the quiz. So we are going to discuss more about this topic. Welcome.
Hello, everyone. Thank you very much for introducing me. Thank you, everyone, and to all professors for the great lectures we were honored to receive today. I think we can start our quiz. You can find the link in the chat, and we'll be waiting when people join, and we will start our questions.
So they have to go to the browser and write kahoot.it and then enter the pin to join this quiz.
Yes. Okay, great.
So Nargisa, let me know when we can start.
Okay, 1 second. I want you to join.
So we have 22 participants now. Shall we start?
Yes, just a second. Yeah, we can start now.
Can we get some more people to join? There are enough people. I'm sure we can get some more.
25 now.
Dr. Nargisa, while we are waiting, can I ask some questions for the presenters?
Yes, yes. Of course.
Is it possible to diminish the sound? Thank you.
It's not in my hands. Mr. Imad, could you decrease the sound, please? Yes, thank you.
Can we start the quiz, please?
Okay.
We are going to start now? Okay. Sorry. Yeah, I was thinking about gaining time here.
Okay, if
Okay.
everyone has joined, we can start.
Now I'm starting. Okay.
Okay.
So the first question is, which of the following is the key advantage of endoscopic spine surgery? complication, higher blood loss, reduced tissue trauma, and quicker recovery. Requirement of spinal fusion is the second. Correct placement of screws using robotic arm is depend on calibration of the operative table, surface measurement dimension, diameter, validation. What do approved robots do nowadays in spine surgery? Resect a spinal tumor, place a pedicle screw independently, act as a drill guide for surgeons to place pedicle screw, decompress the spinal canal independently. In intramedullary spinal tumor surgery, the most critical intraoperative tool for presenting function is 5 fluorescence, bone wax, physiological, The next question is, oblique lateral lumbar interbody fusion primarily provides access through the which anatomic corridor? Oblique retroperitoneal approach, transforaminal, paraspinal wheels approach, posterior midline. The next question, according to WFNS recommendation, first line management of non-specific back pain is opioid therapy, immediate surgery, prolonged bed rest, positive The next question, in resource limited setting, the key principle for managing ruptured aneurysm is fasting performing Next question. In endoscopic lumbar fusion, which of the following benefits is most significant? Higher infection detection, stay and minimal learning curve, hard Next question. Remodeling of the neck and dome in aneurysm clipping primarily aids in minimizing bone flap size, reducing intraoperative rupture, avoiding vasospasm, preventing hydrocephalus. Next question. In insular cortex, is the best approach through which surgical corridor? Transcallosal, transcortical frontal, subtemporal, trans. Mr. Amat, if you can see the results, could you... Okay.
Thank you, everyone. So now we are going to move to the closing remarks.
Is it possible, Mehmet, if you could give closing remarks, please? Miro can't make it since he's on the road. Mehmet, are you there?
Yes, I'm here. Yeah.
Thank you.
It was a great session again. I don't remember how many similar young neurosurgeons webinars we have done. This is fourth or fifth, Salman?
I think it's fourth. Fourth.
Yeah. It's great, really. Salman and Imad has done a lot to collect all these great speakers in such a half day, and I'm very glad to see young neurosurgeons, their motivation, their enthusiasm that will replace the seniors very soon. I wish we will meet in future meetings again with similar fashion. Thank you, Salman. Thank you, Imad. And thanks all the WFNS committee chairs and the committees.
Thank you, Mehmet. Thank you, everybody. Thank you, Keenan, for helping, as always, and all the girls and boys who have helped. Thank you.
Thank you so much, Professor.
Imad, can we have a group photograph?
Group photograph.
Yes. Everyone, please switch on their camera.
Everybody, please switch on your camera. Imad, are you ready?
Yes, sir, I'm ready.
Okay, smile, everybody.
Yeah, please smile. Okay, thank you very much.
Okay, thank you. Bye-bye. I'll see you later.
Bye-bye. See you.